So, oh no, this way, better. Once again, good morning. Let me start and open this our after party, scientific after party after Eshre, which becomes slowly traditional for our company and for our relationship. And it's a great pleasure to open this wonderful event in such wonderful audience. I should say that in these days, you and myself, we have visited several scientific symposia of pharmaceutical industry, and we all witnessing that there is quite a stagnation in the development of pharmaceutical knowledge, and there is very little novelty and practically no breakthrough that pharmaceutical companies can produce and propose to you as a solution of your everyday routine problems. Indeed, not very much has happened in pharmaceuticals during last years, and all the innovations come on account of better media, better equipment, better experience, education, embryological part, but after the introduction of all the recombinant compounds necessary for the successful ovarian stimulation, there is not much that can be changed in the protocols of stimulation and treating women and men. In this situation, indeed, the continuous medical education of doctors' audience is becoming of utmost importance. And this is why we are doing our best to bring to you the best clinical and scientific practices from all over the world. And that's why we build up such an environment that you can freely contact the best speakers and best doctors having their practices most effective and most novel way. And you could here address all your questions, all your doubts. Here you can discuss the problems which you need for the improvement of the results of your own IVF labs. Indeed, this year we have chosen the very important topic for all of you, and we have been discussing that with many doctors, which topic we should pick up for today's meeting, and recurrent implantation failure appears one of the most burning issues, and that's why it's brought up to the scene today. And I'm really very, very happy that we have the possibility to discuss this issue with a constellation of world-renowned speakers and doctors with the international reputation. And thanks to them for coming and for taking our invitation, and also thanks to all of you for presence here. Also my credits and thanks to our long partner and friend Diego Escura, always reliable, always knowledgeable, always so interesting in his presentations and moderation of the scientific sessions. And I'm sure that today's event will be very successful and burn up again new interest and help you to satisfy your hunger for new knowledge, for new things, new methods for improving your everyday practice in your IVF laboratories. I wish all of you very good health and success and peace to your countries and your families. And let's start.
I need to start. It's me, the one that's starting. Hello again. Oh. this is too much, okay? So, can you bring it a little down, please? Okay, so one of the things that happen is if you go to I went to the Congress Center and I saw that everyone is leaving. The place is empty. Everyone is ready to go home after 2 or 3 days of very intense meetings. For me, it's a real pleasure to be here because they put together such an incredible program that supports all of you and try to bring the best speakers and the most knowledgeable speakers are going to be talking about topics that are like really, really key, like when you're transferring embryos that are euploid and they're not getting pregnant. So we're extremely lucky because we have a good friend of mine, okay, and a fantastic doctor, okay, Dr. Nick Macklon. An applause for Nick, okay, please, okay. That it's, aside from being a great human being, okay, it's a great professional that is going to be educating us what may be the major reasons why this is happening, Nick, right? It's common, right?
We all see it. It's very frustrating.
So why don't
we're going to be talking about that with some really good speakers today.
Yeah. Why don't you tell us about what you think about, what are your thoughts about why this euploid
I will do that.
Great. So thank you so much.
Well, thank you, Diego.
It's okay.
And it's really great to be here. Thank you for the invitation, Vlad, to all the team, for inviting us and arranging this meeting. I enjoyed it so much last year. I was delighted when I was asked back to speak to you on what is, a very challenging topic. It's frustrating, as this little girl is making clear to us. We think we have a good quality embryo. It's a chromosomally normal. We've done the testing. We put it back, and it doesn't stick. And where do we go from there? So it is something that we see in practice. And I think we are now getting into a phase where we're beginning to understand why this might not be happening and getting some idea for some strategies of how to deal with it. So these are my disclosures. And I think let's go straight to we've got this lovely analysis from Simedimo from Italy, where he actually asked the very question, why don't euploid embryos implant? And many of you will be familiar with this analysis, which I think has been really, really helpful. So let's go into what they found from looking at the literature. So they looked at a number of studies, both randomized controlled trials, observational studies, and put them together to see if they could find any factors that were emerging from these studies using euploid embryos that seemed to be having an influence on their chance of conceiving. And there's no doubt, as you will, I think, recognize from your practice, that it's not just about the chromosomes. We also score the embryo in many ways, still relying on good old morphology, the Gardner's score, or other scores with which we're familiar. And these studies showed very clearly that a good-looking embryo has got a better chance of implanting as euploid than a euploid embryo that's struggling in other ways. And that is intuitive, and we might expect that. And the interesting thing, I think, that's emerging from these studies now, and as we understand more about mosaicism, which I'm sure we'll be talking about later, is that there is a big discussion beginning to happen now whether or not morphology can sometimes trump euploid status. So if you have a euploid embryo that is not looking good morphologically, you've got a low-grade mosaic, which is high quality, people are beginning to think about there may be indications where, in fact, you rank the mosaic higher. Now, this is still in the research stage, but that discussion is beginning to happen, which I think is quite interesting. The rate of blastocyst development is another marker, and we've got good data showing that the day 5 embryos, if they're reaching the blastocyst stage and they're euploid, they'll do better than the slower euploid embryos. So we can take that on board, and that can be a reason. What about the maternal side? Interestingly, we've tended to think that if you've got a euploid embryo, you've removed the maternal age factor. And while that is largely the case, it's not completely so. And so there is some evidence that the younger woman with a euploid embryo will do slightly better than the older woman, pointing to perhaps other aspects of embryo quality which are determined by age, or indeed a maternal element here. So we're beginning to get some pointers from this, and some other ones which don't seem to be an issue. So when they looked at polycystic ovary syndrome, that condition doesn't seem to affect the chance of a euploid embryo transferring, despite the concerns there may be about egg quality in some women with PCOS. But obesity does seem to be an issue, and we're seeing that emerge in a number of studies now, that a high BMI is becoming a predictive factor, a clear predictive factor for success in IVF, and it does seem to be affecting the chance of a euploid embryo. Now, all of these are pointing to a maternal element that's probably beyond the embryo itself, but pointing to some maternal aspect which is influencing the chance of that embryo implanting. And I think these are all things that we should be discussing with our patients. So I think they summarized, those of you who know the paper will be familiar with, I think it's very helpful visual abstract, graphical abstract, which basically summarizes the factors that they looked at and the odds ratios for the chance of implanting. And we'll be coming back to look at the RIF1 a little bit later, the recurrent implantation failure. So we do have some answers now as to why the euploid embryo might not be implanting. But we have had the discussion, and Paul and I have shared the platform a fair amount over the last couple of years talking about recurrent implantation failure because of the very important publications that they produced a couple of years ago, and I'll be talking about that briefly, and I'm sure Paul will, that we have been having to adjust our definition of recurrent implantation failure. When we used to transfer many embryos, it would be not unusual to transfer 10 embryos and not to succeed. That was quite common for a whole range of reasons back then. And then we moved more to single embryo transfer. We've had to adjust the definition of recurrent implantation failure to account for that, so that now if we transfer 3 good embryos, we tend to start getting concerned. And as some of you may know, I've been working with the ESHRE group to try and revisit this definition, and I'll touch on that at the end of my talk. But what has emerged is a very real question from the study that Paul did and the subsequent study by Gill, which again I think you'll be familiar with, but I think we need to just acknowledge. And this is the paper that was published in Fertile Sterile back in 2021. And what Paul and his colleagues were able to do was to identify a cohort of women who had access to serial euploid embryos, which is great, and transferred 1 and looked to see who got pregnant, and those that didn't, if they had access to another euploid embryo, they went to that transfer, and those that didn't get pregnant from that went to another, and you can see the study design there. So a large cohort of patients that were able to address this question. And the key, I think there were 2 key findings from this, which were really important. The first one was that overall, if you have access to 3 euploid embryos, you will probably get there. Almost certainly, in fact, 95% cumulative pregnancy rates. So the idea of just keeping calm and carrying on with your euploid embryos is probably very appropriate. The other one was there seemed to be, even if you've had 2 euploid embryos transferred, the chance of the 3rd one implanting was still pretty good, around about 60%. And this raises the question, I think a very reasonable question, if you have a good enough quality embryo, is there a maternal factor at play? Because why isn't it emerging in this cohort of patients where we might expect if they didn't get pregnant after 1 or 2 euploid embryos, there may be something going on the maternal side. And yet they didn't really see that because the group that had the 3rd euploid embryo had a very good chance of succeeding too. So these are very key questions that we have to think about. So a very reasonable conclusion from that then is that if 95% of women with euploid embryos will get pregnant and get a positive heart, an ongoing pregnancy, this means that recurrent implantation failure as a biological phenomenon must be very rare. As a biological phenomenon, must be rare. And very few women will reach that stage of a 95% chance, though, because many will not have access to chromosomally normal embryos, or we won't have tested them. And Baris Ata's paper made a calculation that you would really need to have 7 blastocysts transferred before you would reach this 95% chance if they hadn't been tested. And that's quite a lot in modern practice. That may be 5, 6, 7 cycles. And that was consistent with this idea that recurrent implantation failure then will be very rare if we take on this definition. So let's hold that thought and draw the conclusion, I think, that was made from these papers that really it's all about the embryo. As long as you've got a top quality embryo, you don't need to really worry about recurrent implantation failure. And I think they have shown that actually quite convincingly. However, as somebody who's been researching the endometrium and recurrent implantation failure for a few years, I have to try and align that reasonable conclusion with other observations that we've made, and our own group and others have done this, where we've looked closely at the endometrium in women with a traditional diagnosis of recurrent implantation failure based on 3 high-quality embryos being transferred without success. And in fact, this study was supported by a grant from Merck Serono a number of years ago. And what we were able to do was to identify a cohort of women, quite a reasonable sized cohort of women, and a good control group, and just look at the endometrium, see if it was different between the women with recurrent implantation failure and those that didn't have that. And we divided them into a signature set where we identified what the markers might be, and then a validation set where we validated the findings that we found to see if it could be used as a predictive model. And we were using transcriptomics, and we identified a whole range of genes taken from the endometrium, looking in there, and found a whole range that were disrupted significantly in women with recurrent implantation failure. And what we found was that actually most of these disrupted genes were not specifically related to the luteal phase or even implantation window, as we might expect, but seemed to be more related to follicular phase aspects of endometrial function. And since then, more studies have emerged showing that perhaps our focus just on that window of implantation in diagnosing problems with the endometrium might be oversimplistic, that we should actually be looking at other elements of endometrial function which may be determining whether or not an embryo will be supported in implantation or not. Now, having identified these, we were able to create a model which we validated on the second cohort, and it seemed to be remarkably predictive of the clinical phenotype of recurrent implantation failure, which you can see the area under the curve was pretty impressive for a biological process. Now, I don't think we would want to go further in making other conclusions that this would serve as a clinical test because we haven't tested it in that way. But what it does indicate that there probably is an endometrial factor contributing to recurrent implantation failure in at least some women. And in our group, around about 1/3 of the women with this clinical presentation were found to have this pattern of being expressed in their endometrium. We then went on to do some more clinical studies. When I was in Copenhagen, we set up our implantation clinic there for these women and simply looked to see if they differed in other ways from women without that history. Similar study design, which we published a few years ago. And you can look at a few things. We looked at vitamin D levels, progesterone in the mid-luteal phase, endometritis, whether or not the ERA was displaced, and whether there was an unfavorable microbiome. And interestingly, the only one that really wasn't significant there was the ERA test. We didn't find any statistically significant difference between those two groups in there. And again, small cohorts, we have to be cautious about how we interpret this data, but from the purpose of a discussion about possible causes of implantation failure, it does at least give us some pointers as to where we might want to look in further studies. So that creates a little bit of a dilemma, because we have on one side this very convincing data that as long as the embryo quality is good, you're getting extremely good outcomes, and recurrent implantation failure is hardly ever going to arise. And I think that is a fair observation. On the other hand, we are finding something in these women that is outside the embryo. So how do we reconcile those two elements? And that's what I want to touch on a little bit now, and it's a hypothesis, I suppose, that we've been able to put forward in a recent paper if you're interested. So how do we reconcile the embryocentric and the endometrial-centric views on recurrent implantation failure? I believe we can do that. And with starting point is an acknowledgement that embryo quality is not on, off, good, bad, black, white. It's on a continuum. I think we're all quite comfortable with that. We're used to seeing that in the way we score our embryo quality. We have a graduated score from top quality down to what we might consider as so unviable that they're unlikely to succeed at all. And this has also been shown to apply now to their chromosomal health. So at the bottom of this, we will have the euploid embryos with a very high chance of implanting, and at the top we'll have the aneuploid embryos, which we now know will not produce a live birth if they're transferred. We've got excellent data now from non-disclosure studies where these embryos were tested and transferred without knowledge of what the euploidy status was. So we're learning much more about it. And what we see is there's this middle ground, perhaps mosaics, where perhaps the outcomes aren't quite so good, but many of these embryos will implant and produce an ongoing pregnancy and indeed a live birth. And what we're also beginning to understand now is that this mosaicism, mitotic mosaicism, is probably very common. If we look hard enough, as Ostap did from the Rotterdam group, published in JCNI a couple of years ago, where they didn't use just the commercially available tests for assessing chromosomal health of the embryos, which, as you know, involves taking a biopsy of 4 to 5 cells, but actually they looked at every cell in the inner cell mass, but also in the trophectodome. And if you do that, you actually realize that we're missing a lot with current testing. Whether that's clinically relevant is another question, but from a biological perspective, it's interesting. Because what they found was, if you look hard enough, 82% of good-looking blastocysts, those that we might consider to be euploid on standard testing, or indeed mosaic, did in fact have at least one abnormality and one cell. Now, one of the questions that this raises for us is whether or not, if it's so prevalent, minor mosaicism, is it actually part of normal embryo development? And could it even confer an advantage? And that's something we can maybe discuss later on. But we have to recognize, therefore, that this notion of us all having been euploid embryos can be challenged. And in fact, from this work, I think we need to recognize that most of us were probably not completely chromosomally normal embryos, but that the abnormalities that we had were minor enough for our mothers to accept us to implant, and were minor enough for us to deal with as embryos so that they didn't have any clinical impact on us late after delivery. So it does change the way that we think about chromosomal scoring and assessment of embryos. But I also think it changes the way we need to think about how the endometrium deals with these embryos. Because if many of the embryos are mosaic, if we say accept 80%, we need more studies to confirm this, of course, but if we say the majority of embryos presented to the endometrium will have some sort of chromosomal abnormality, which is consistent with viability, then it means the mother has got to make a decision as to whether that chromosomal abnormality is severe enough to reject the embryo or whether it can be accepted. And last year, those of you who attended will remember that I was talking about this in a little bit more detail. The work that we did with Jan Brosens, developing this idea that there was this biosensor in the endometrium that allows a decision to be made by the mother as to whether she's going to invest in allowing an invasive but possibly poorly viable embryo to implant or not. And I'm not going to go into this in huge detail this time, other than just to show you the sort of studies that were done at the time, where we're able to show, for instance, in vitro culture, where co-culture, where you have an embryo there and decidualized stromal cells. In the middle, we have a high-quality embryo, and you can see the stromal cells engaging with it, reaching out to it even, but when there's a lower quality embryo, the cells seem to recognize that and do not make that commitment to that embryo to allow it to implant. And we were able to summarize this in a figure which I think many of you will have seen. And that is this developing idea that it's not just about receptivity, that's clearly important for the endometrium, but also about its selectivity. And what we've been able to show from other studies that we've followed with is that some women with recurrent miscarriage, they've got this balance wrong. They're super receptive, but they're not selective enough, and they're allowing poor quality embryos to implant long enough to get a positive pregnancy test, miss a period, get excited about a pregnancy, but sadly then lose it later than actually nature intended. Nature intended for her to make a decision much earlier before she even knew she was pregnant, if you understand what I mean. So if that balance is wrong in the other direction, then we might see an over-selective endometrium that only will allow embryos to implant that are absolutely top quality, and maybe in some cases won't even allow them to implant. And I think what I'm trying to say with this slide is we need to look at the endometrium the same way we look at the embryo, as being on a continuum of function. Not off, not on, not receptive, non-receptive, but probably in most cases, somewhere in between. And this is something we're familiar with in reproductive biology in many other ways. Sperm counts, whether women are ovulating every month or not. There tends to be a continuum there, and the one can compensate for the other. The man with the very high sperm count and the woman who's not ovulating every month, they still may not come to our clinic because they'll get pregnant the first time she ovulates. So one compensates for the other. And I think that we need to think of this implantation process in a similar way. Now, where has this study got to now? Well, Jan has been working on this for the last 10 years, trying to elucidate how the biosensor works and how we can measure it and how we can treat it. And this paper was published last week in Science Advances, and they've been taking biopsies of the decidualized cells in a large cohort of women with recurrent miscarriage, and have shown that this abnormal decidual reaction, where the balance between receptivity and selectivity is wrong, is closely correlated to the recurrence risk of miscarriage. So not all women with recurrent miscarriage will have this as the issue, but there is a cohort that seems to. And from this, they've also been able to see that prior miscarriages seem to have some ongoing impact on this. And this could be one of the reasons why, as women have more miscarriages, their chance of having an ongoing pregnancy diminishes slightly. That it's actually having an impact on this balance between receptivity and selectivity every time. And then over time, as they keep having a miscarriage, this decidual quality erodes and becomes less and less capable of selecting the correct embryo or allowing the good one to succeed. Now, the question then is, well, what can you do about it? Well, they've been running some studies looking at a type of oral hypoglycemic, which seems to be able to modify this response, and we're waiting to see the data from that. But I think what's encouraging about this work is it's pointing us towards new tests to understand recurrent miscarriage, which, let's be frank, we haven't really had an effective therapeutic yet for this, that there may be a route where we can identify a group of patients where this is the problem and we might be able to do something about it. So this is, I think, a very beautiful paper to read, and has actually been met with great enthusiasm by, as you can imagine, the patient groups and indeed the media in the UK. So where this brings me then is to this figure, which I hope will summarize the way I think we need to think about this. And that is considering that implantation, the successful implantation, will depend on both the embryo and the endometrium. And along the x-axis, you can see if you have a low-quality embryo on the left there, then irrespective of what the endometrium is doing, it will not implant in most cases. And that's what nature would intend. If we don't want a low-quality embryo to establish a pregnancy, and that's fine. On the other hand, at the other end, you'll see that if you have a high-quality embryo, let's call it a euploid embryo, then the endometrium doesn't need to be great for such an embryo, we've probably got a good chance of getting a pregnancy in most cases, and that's what we see in the clinical studies. But the point is that I think in most cases, the embryo will not be perfect, and neither will be the endometrium. And it's those times that the combination is going to become important in determining the outcome of that embryo transfer. So if the embryo is all right, and the endometrium is not terribly receptive or overly selective, then that embryo is not going to make it. But if the embryo is all right, and the endometrium is very receptive, then we may see a pregnancy arise, and hopefully that pregnancy will go well. But what our work also showed was that you can be too receptive in the endometrium, and indeed that's the work that I've demonstrated with the recurrent miscarriages, so that you could have the situation arising whereby the embryo is poor quality and not really viable, but because they're super receptive and not selective enough, it's allowed to implant, establish a pregnancy which is unfortunately destined to end in miscarriage. But for the purpose of this talk, I'd like to draw your attention to the other end, where it won't matter. If the embryo is top quality, it doesn't matter if the endometrium is not functioning perfectly or not being selective enough, because the embryo is normal, and it will survive, and it doesn't matter that it hasn't been selected out. And if you've got that super receptive, then your okay embryo may well survive, and I suspect there might have been some of us in this room who've got to thank our mothers for allowing us to implant when we perhaps weren't perfect embryos, and I certainly count myself amongst that group. So, where are we going next? Well, I want to show you a study which was published recently. It's fair to say that it's courted some controversy. But I want to focus on you for a particular element in my argument today. And this is a randomized controlled trial that was recently published by Nathalie Leday's group. And they've been working on a test of endometrial receptivity and trying to link it into a therapeutic approach. It's based on a concept or a notion of immune activity, which again is also controversial, the role of the immune activity as a treatable cause of implantation failure, and I'm not going to get into that discussion today, that's for another day. But it's an interesting study from the point of view of the discussion we're having now, because I think some interesting data came out of it. So it was a randomized controlled trial, mid-luteal endometrial biopsies, profiling of a number of markers, NK cells, and we'll talk about those a little bit more in a minute. And then they were randomized to either receive an adjusted treatment protocol to address the immune findings, or to have no change to their treatment and not have any intervention. And what I'd like to focus on here is not the overall outcome, but this particular element, which I was quite interested in the context of what I've been saying. What they found was, and what they reported was, that there did seem to be some benefit of using this test. Again, it's a fairly small study, and we've got to be very cautious about how we interpret that. But I was interested in the fact that that difference was only evident when the embryo was not top quality. When the embryos were good quality, they didn't see any impact of this test. Now, there may be a number of reasons for that. The test might not work, and the intervention might not work. But interestingly enough, it certainly didn't work when there was a high-quality embryo, but it did seem to have an effect when the embryo was less good quality, suggesting, I think, that when the embryo is less good, that is when the endometrium might matter. And I think it provides some evidence, clinical evidence from a trial to support the theory that I'm putting to you today. So, from what I've said, it would seem that the endometrium probably has no role when the embryo is euploid or top quality. And is that really the case? Well, I don't think it is. There's very rarely absolutes in reproductive biology, as you all know. And if we go back to the Simondimos study, we can see this evident here, that amongst women who had access to euploid embryos, those women with a history of recurrent implantation failure had a slightly lower chance of succeeding. And we also have data, which I think we'll discuss again later from this extension study on a huge cohort of patients where they were able to identify women who had access to 5 euploid embryos. And as you see, almost 98% cumulative pregnancy rates, but not 100. And as we get up into embryo 5 and 6, we are beginning to see a fall in the chance of implantation of that euploid embryo, suggesting that an endometrial or other factor is beginning to creep in. So it's not so simple. There's going to be some other factors there whereby even the euploid embryo might not make it. And we can think fairly quickly about reasons why it might not, that could lie in the uterus at different phases. The embryo might go into the uterus, it might just not fail, it might fail to thrive, it just might be too poor quality to do that, of course. But there may also be a rather hostile endometrial environment that it's encountering, which just doesn't support it, whether that be endometritis or a pH that's not right, or the O2 level. All of these things we still need to learn about in the uterus. It may have thrived but failed to initiate implantation, so there may be asynchrony, there may be an inherent receptivity problem, or it may have even started implanting but not made it through, and I think that's happening a lot in IVF, but also natural conceptions, where there may be a role here for the degree of immune activation, or indeed disrupted biosensor function, and as I've said, we're beginning to see tests emerging which may show to be useful in a clinical setting. Now, I just want to finish by touching on a study that we've done, actually using this test in a research setting in London. Again, not as something that I would say is something we all need to be doing by any means. We need a lot more data before we start considering that. But it also is quite helpful in addressing the question I'm talking about today. So we've just published this paper, Endometrial Immune Assessment in Patients with a History of Previous Euploid Blastocyst Failure. Now, it's a small study, so let me start with this. We have to be very cautious in looking at these data. All it does is provide us some potential pointers. These women underwent a substituted cycle ahead of a frozen embryo transfer, a mock cycle, and we took a biopsy. We sent it off for testing, and the sort of things that were looked at are shown there below. Mona Ramati in my group, who did this trial, she used to work in Natalie's group, so is aware of the science that's been going on there. And this was then interpreted in this way as being either balanced, overactive, underactive, or indeed mixed, on a range of markers, not just NK cell counts, but some cytokines and a whole range of markers which are known to reflect the degree of immune activity in the endometrium, for which we need some. And the reason why I've been enthusiastic about this is it's moving us away from thinking about immune response to the embryo as always being a bad thing. Many of you will know perhaps some colleagues who are always trying to suppress the immune response in patients. We know we may be doing more harm than good in some patients there because we need some immune cells there. NK cells are good things in the endometrium as long as they're functioning appropriately. So what they're trying to do here is identify whether or not a woman has what might be seen as an appropriate immune response, or active or underactive, and then develop an intervention around it. And again, preliminary data, not prime time by any means, but what I like about it is it's linking recurrent implantation failure with a diagnostic and a targeted intervention, rather than just saying it's recurrent implantation failure, let's throw steroids and intralipid at it, which I think most of us would now agree is probably causing at least as much harm as good. Now, these are the interventions that are advised when you use the test. If it's overactive, some steroids in that case, and a higher dose of progesterone, which we know is an immunosuppressive, or an endometrial scratch to stir up the immune response in the mid-luteal phase of the next cycle, should they come back as underactive, and some other steps there. As I said, it's a small group. We had 609 in whom we biopsied after their first attempt of euploid transfer, some who'd had a previous euploid failure and no immune profiling, and then went on to have a second euploid transfer, but without immune profiling. So what we were looking at here is there any sign that after 2 embryos, or after one euploid embryo, if it doesn't work, we can improve things for the second euploid by focusing on the endometrium. That's simply the question that was being asked here. And this is the intervention that was given. Again, small cohort of those that did have a second euploid embryo with testing, so the necessary caution required here. But we were interested to see in the results that those people who had a previous euploid failure and no profiling had a 51% implantation rate, whereas those with immune profiling had a 65%. Now, small cohort, as I've said before, so please take this with the necessary caution. But it is just pointing again in the general direction of there being a role for the endometrium in those patients who have serial euploid embryos but don't quite make it. And there may be some value in looking at it. And this is just another way of looking at the data. The first attempt, euploid, 63% implantation rate, 55% ongoing pregnancy rate, and live birth, 50%. The middle one is where they then had a second euploid embryo, but without any testing, and you can see the results are not so good with the second euploid as the first, but when they did have testing, it was as good as with the first euploid. So that's the message from this is simply that we should not be ignoring the endometrium, even when we have euploid embryos. So I just want to finish with one perhaps more practical thing, having spoken about theories really up until now, and that is the guideline, which I hope you're familiar with, that we published a couple of years ago now. And just to remind you that rather than the 95% cumulative cutoff, which has been proposed by some, the SRA decided that that was too high and that too few people would actually be diagnosed with recurrent implantation failure to reflect our clinical practice, the realities of clinical practice. And this was a long discussion, but ultimately this is the SRA definition of recurrent implantation failure that made it. And it's fairly straightforward, at least in terms of how it's defined. Basically, if the patient in front of you has had a 60% chance of conceiving, but has not made it yet, it might be worth looking further to find out if there's something that needs further investigation. That's essentially what it is. And for one patient, that will be 4 embryos transferred, and another, it might be 2 or 7. It will depend on the age of the patient, the quality of the embryo, the quality of the clinic as well. And as time goes on, we're getting the machine learning techniques to really produce very accurate predictive calculations of what chance patients have of conceiving from a cycle, indeed what their cumulative chance will have been to date. So I'd encourage you to have a look at that paper. And I'm just going to show you the 2 tables which were put in to try and help clinical practice in day-to-day life, because not many of us have access to sophisticated means of calculating cumulative chances of conceiving in a particular setting. And the key thing here was two points. One is, do we know that the embryos have been transferred were euploid or not? And how old is the patient in front of you? So just to illustrate this table, if you have a patient in front of you who's less than 35, and she hasn't had her embryos tested, then using the models that we employed, and they're listed in the paper, only once the woman had had 3 embryo transfers and failed to conceive did she cross the 60% cumulative chance threshold and could be considered to have recurrent implantation failure as a clinical diagnosis. If she's 35 to 39, it needs to be 4 embryos, and if she's over 40, it's actually 6. All right. So we really should, but in our patients above 40, we should not really be getting concerned about other factors other than the embryo until they've had 6 embryo transfers. That's essentially what this is saying. Not 3, but 6, based on age. What if the embryos are euploid? Well, the studies we have available suggest that the best thing probably is just to keep calm and carry on. But there are other studies, including the small one we've recently published, but there are much larger ones out there suggesting there may be a slight drop-off in chance of implanting of euploid embryos. And in that case, if you know that they're euploid, once you've had 2 transferred, the SRA guidelines suggested if you haven't conceived after 2, it might be worth looking at other things. And the tests and the interventions are all described in the guide, which I recommend you to read. So I'd like to conclude by thanking you again for your attention today and for the invitation to speak. We have to remind ourselves, don't we, that this focus on chromosomal health, yes, it's been partly driven by biological rationale, but probably also by companies' enthusiasm in the testing. But it is clearly an important element of embryo viability and something that we can now look at, but it's not the only aspect. Factors predicting the outcome after euploid transfer are beginning to become elucidated so that we can sit with our patient and say, well, look, do you have any of these factors that could explain this? And I think that's becoming very helpful. We're beginning to understand how the endometrium works and that it's much more than just receptive or non-receptive. And this allows us, I think, to reconcile the excellent outcomes we see with great quality embryos where the endometrium is probably less important and those where they're average when it is. And I do think that we're beginning to see studies emerge that are pointing towards the potential value of endometrial assessment. Now, as I said before, we're not there yet. We need a lot more work. We need to identify what functions we're testing, and we need to identify interventions that will work. But at least we can now do the randomized controlled trials looking at targeted interventions rather than blind ones, which is what we've been doing to date. So thank you very much again for your attention.
Thank you, Nick. That was fantastic because this is like a question mark all over the world. And we're going to have a big discussion later on because now we're going to have Paul. But
yes.
Truly fantastic. I have so many questions that I wrote down there, and I'm sure they did too. So now we're going to continue. So we're going to have 20 minutes of discussion after this, which is great because I'm sure that you have the same questions that I have. But Nick gave us so many answers already, and putting something in place that actually, I think that Paul is a senior doctor at Forge, that's like at the unit of OBGYN. And hi Paul, how are you?
I'm very well, thank you.
You know, it's the first time we met, okay?
No.
No? Sure?
No.
Well, it's good, but in a meeting like this, for sure, it's the first time, right? So, you know what? His talk is going to be easier, probably, because after what is being said by Nick, you're going to be telling us what is true about the rate of recurrent implantation failure, right?
Let's just say we agree to disagree.
Well, I love that. So let's hear Paul, and then we're going to have a very good discussion together, okay?
So, hello everyone. Thank you for inviting me to this very nice event, and congratulations to you to have survived the charms of Paris. I think that by being here today and not leaving from Erfurt, because just so you know, tomorrow there is a strike. So if your plane is tomorrow, be sure to check whether you still have a flight, okay? Anyway, you can stay in Paris. It's going to be less cold, less warm. So today I'm going to talk to you about the concept of recurrent implantation failure. And it could be that some of the slides will be contradicting whatever you have heard before or you have known before. So, so I have no conflict of interest with respect to this talk. So the objectives of my talk will be to try to tell you how frequently euploid embryo or blastocyst implant. It's very important to understand that at least how often do they implant, because they are a big part of implantation and success. What is the chance of implantation with sequential euploid embryo transfers? What is the threshold for diagnosis of recurrent implantation failure? I will call it SRIF from now on, so please be aware. Because it could be that there could be different definitions to respect to clinical research and clinical practice. Because it could be that your patient will not be able to comply with very exigent definition. And there are a few assumptions, because first of all, that you do the biopsy at blastocyst stage, not cleavage stage. This is very important. And that all transfer are a result of culture, prolonged culture. And that all transferred in frozen embryo cycles, because you have to be sure that you have the synchrony between the embryo and the endometrium. Otherwise, if you compare fresh and frozen, it's going to be very complicated to define if it's correct or not, or similar or not. I think that in today's ART, when we talk about recurrent implantation failure and how often do we fail to achieve outcomes in ART, it's very important to understand that we only tell our patients how often they will succeed, and we will never tell them how often they will fail. Because failure, we hide it under the rug, and we don't talk about it. And it could be that patients don't understand that failure is a part of reproductive, because although we believe that we are, with ART, we are doing better, we are all under the less than 100% efficiency of human reproduction. Humans do not have 100%, and I don't believe that probably in the next 10 years we're going to achieve 100% in terms of you put an embryo and it becomes a baby, because there are different limitations, and also different limitations in terms of law. So the question is, what is recurrent implantation failure? Well, when I was in the US and I talked to Richard Scott, which was my mentor back then, he told me, Paul, in the 80s, RIF was probably 90%. Because back then, in the 80s, when IVF began, the performance of ART was around 10%, okay? Now we are talking about 10% RIF. Back then it was 90%. But if you were to look of everything that we have done since, all the evolutions that you have been in the lab, not patients, in the lab. So our practice and our way of dealing with embryos has evolved and actually assured that you have achieved 70% nowadays implantation over one euploid embryo transfer. So we passed from day 3 to day 5. We changed catheters. We started to do ultrasound when doing embryo transfer. We have started to understand better the endometrial thickness and patterns and so forth. We started to do hysteroscopies to check for polyps and so forth. And not to mention, we have started to do freeze-all, which had less hyperstimulations, more eggs retrieved, more successful cycles, and not to mention PGTA, who actually pushed it even further towards 70%. So every progress that we made was in the lab, and we have improved our workflow. So indeed, there are still 30% of patients who don't implant, but, and I fully agree with Professor Macklon that chromosomal competence of the embryo is not everything. Competence of the embryo is still very important, because it's not only about the genetics, it's also about the mild mitochondrial processes and so forth. So with this respect, you're going to find in the literature many papers telling you what could be a cause of RIF. And indeed, there could be potential endometrial factors, but it could be also, for example, iatrogenic factors. For example, in vitro fertilization protocols related, like in the lab, our process. It could be genetic, immunological, infection, so forth, thrombophilia, whatever. The thing is that few of these studies will tell you what RIF is. So they say it could be a cause of failure, but it will not tell you what actually that failure represents. And the question is, what kind of data do we need to be able to have a compelling definition? So in defining RIF, I think that if you look nowadays, actually I just saw a paper saying that there are more than 600 definitions, anyway, different. I've only found 78. Call it, I'm just lazy. But anyway, you're going to have 78, but the most common that comes in papers is the one from 2014 from Carol Kaufman, stating that 3 embryo transfers or 4 blastocyst transfer for those who transfer multiple embryos has remained the consensus that people use even today. Now, the question is, if you would apply this definition to your research, let's say tomorrow you're going to have €1 million, you're going to have a nice study, and you're going to apply this definition, it could be by the end you're looking at the wrong population of patients. So you're not going to have not going to achieve a correct answer to your objective of study. And why is that? Because, well, it doesn't mention age, which is quite odd, because all we talk to our patients is age. If you have a patient tomorrow, she's 42, regardless of how many eggs she's having, you're going to be very less than optimistic about her chances of having a delivery. So these definitions do not surprisingly mention age. Now, why age is so important? So Jason Fernasiak showed this in 2014, that actually aneuploidy is very important, and it can shift quite a lot the incidence or the prevalence, starting with 35 years old. And it could be that this explains why older patients are more prone to fail again and again because their embryos are not good enough, regardless of how good endometrium is. Also, another factor that came into our view is that patient can have aneuploidy again and again. So this is a study by Sarah Herlihy that actually showed that people can have a high incidence of having complete aneuploidy again and again. These are those patients who do transfers and never succeed, and it's not because the endometrium was not working or immunologically fit or synchronized. It is just because they didn't get competent chromosomal embryo, not to mention other kind of competence of the embryo. So RIF is a very complicated scenario. Most definition will not consider age. In terms of research, if you cannot define uniformly a pathology, how can you actually start doing research on it? And clinically, if you can't research a disease, how can you define the prevalence and actually assess literature or propose therapy for it? So therefore, you have patients requiring intervention that lack evidence, clinicians that will prescribe non-validated treatments, and investigators that actually lack baseline fundamental for research. This is why we always believe that we should have an up-to-date RIF definition, because it's important in order to understand why those 30% of euploid don't implant. We need to have a better definition, and research should be done in a way that you look into this population and try to understand more, because it could be that sometimes endometrial factors can, and not only, but can be a part of failure, but not necessarily recurrent. So to understanding RIF, recurrent implantation failure, we should begin by defining it, and it should exclude those circumstances where you have obvious causes of failure. For example, extreme maternal age, extreme diminished ovarian response, let's say a very atrophic endometrial, and also it could be that defining the population that will be eligible for diagnosis of RIF, you should consider probably only euploid embryo transfer, because you have to control for something. You cannot mix them all. And I do agree mosaic represents an interest population, but it could be that in the future we should actually do a trial using mosaic, because mosaics have been shown that have more or less the same implantation rates as euploids. But the mosaic in itself represents a population of embryos which is very variable with respect to the platform of PGTA that was used. So this is why it's very important to understand mosaic embryos, although maybe some of us were mosaics. The problem is that putting mosaics in a trial, it will be highly biased, because it could be that the numbers of mosaics that you have, called embryos, will be actually depending on the platform of PGTA that were used. Because the problem with PGTA is very big. Most of the platforms that are used were not validated correctly prior, and therefore it's debate for over 10 years. So this is, I think, the requirements that we should actually impose to patients when you want to understand what actually RIF is. And this is important because chromosomal abnormality is important. It's probably the main factor, but in terms of endometrial factors, you're going to have, for example, receptivity. So there are many things that were linked to receptivity, endometriosis-induced receptivity issues, and also immunological receptivity issues. But you're going to have many papers, and this is why we sought to try to understand what to do with it all. Going forward, as I mentioned, this is the only non-selective trial that was done on a PGTA platform by Ashley Tix, and what she showed is that in their trial, no aneuploid embryo delivered. So when you have a PGTA platform and you go look for euploids, those euploid embryos, it's important to understand that PGTA doesn't tell you very precisely how many are euploid. It will only tell you how many are aneuploid, because you can have euploid, mosaics, and aneuploid. So it is very important to understand that when you have a platform, you have to validate it and make sure that no cold aneuploid will be surprisingly delivering a baby, because in that case, your platform is wrong. And errors of platforms have been described. So in this publication that we made, we use this platform, which have been proven to be extremely efficient for aneuploids, not euploids. It's very important. So we know that euploid rates range a lot, yet again, because of the PGTA platform that are used, and they can be from 40 to 70%. So not all euploid will implant. The question that we had back in the day is that if there is a cause, is there a persistent cause of endometrial? Because no matter how we look at it, we will never be able to know the endometrial pattern on that cycle when the embryo implants. Because you're not going to do a biopsy on that day and then you put the embryo in. You usually do biopsies the cycle before you do your embryo transfer. Now, acknowledging that the biopsy you do 1, 2, 3 months before will be the same as the endometrium will be in 2, 3 months, it's very, let's say, it's a very big gamble. So our ideology was, if there is a factor, which could be like in 1 month or 2 months, the question is it persistent? And this is why we turned to the question, what if we do successive embryo transfers? We went for 3, and then after it was taken for 5. So the question is, this was a publication in the FNS. So we actually excluded all egg donation cycles or gestational carrier, and of course all patients with less than 7 millimeters. So we end up with all 4,400 patients. We included all BMIs because it's a topic that we're going to address later on, which is important. So what was important is to do frozen embryo transfer, and the second part was to make sure that your uterine cavity is normal. Now, when we rendered the results, we were surprised to see that 70% of them implanted, so we were happy. The platform was there in the higher levels. So as any ART setup, you're going to have patients who fail, patients who drop out for different reasons. From those who remain in the system, there will be patients performing a new ART to get new euploid embryos, but also those with remaining embryos. And then we did a second euploid embryo transfer, 60% implanted. Yet again, you have those who fail, those who do run again new cycles, and those who have remaining embryos. And when we did the third one, we had again 60%. So this was quite surprising, because if there were to be a persistent endometrial factors, your levels should decline all the time. And it didn't. Also, in our reviews that we received during the publication, people said, well, we have this population which have remaining embryos and new embryos. And when we run the numbers, it was the same. And we have to prove them to the reviewers. So, and also we were quite surprised by the difference between the first one and the second and the third one. And our hypothesis was that it could be that morphology has the one selecting the first embryo for transfer. This would explain this difference. So this is the live birth rates for these patients, which were quite concording to the miscarriage rates that are declared and reported during use of PGTA. Now, if you look, this is a Kaplan-Meier estimate. You're going to see that if you have 3 successive euploid embryo transfer, you're going to have 95% of them implanting and 92.6 delivering. So it is quite surprising at that time, and as probably Professor Macklon mentioned, this kind of challenged the definition of RIF. But there are many things to discuss. So the first thing we took from this data is that people who fail the first time do not have an increased incidence of failing again and again. So this is quite reassuring for your patients. Our report was that probably RIF is less than 5%. And we believe that the data that we had and the big cohort kind of put into question whether there is a persistent endometrial factor. Could be sporadic, but not persistent. And then we tried to summarize that in these patients, it could be that additional embryos will offer them hope for a better outcome, and it could be that you should not propose to this patient incredible things that have not shown, like add-ons, because it could be that implantation rates decline minimally with increasing transfers. And when we looked at the data, we actually saw that probably we have a decline of about 5% as average. And we tried to look into the American data because we wanted to see similar models like successive euploid transfer in frozen cycles. And in this group of 18,000 patients, the decline between the first one and the second euploid transfer back in 2020 was about 6 to 7%. So it kind of fit in what we have found in our population. It was again reassuring. Another thing is that then a bigger group with the funds that now have this group of clinics, they were able to get together 123,000 patients. This was a prize paper in ASRM, and what they actually showed that the fourth and the fifth successive embryo transfer, they are always above 50%, and that for them, RIF was less than 2%, because this is a publication in human reproduction, and actually cumulative liber rate with the Kaplan-Meier estimate was 98%. So again, it was a very nice reproduction of the model that we proposed initially. Now, the thing is that when we were thinking about this paper, we tried to think about the cohort effect. So if there were to be a persistent endometrial factor, for whatever reason, you name it, chronic endometritis, whatever, the thing is that this population will represent it in blue. So if you take 1,000 patients, you're going to have, let's say, a 5% RIF, and it will be in blue. So when we talked about this 5%, we were fearing that we are stating something too difficult to accept. And the thing is that if you would do successive euploid embryo transfer, the blue population by the third embryo transfer will be dominant in your population that failed again and again. And in our calculation, if you take 5%, by the fourth transfer, you will have 24% implantation rate, and we had 60%. So this is why we settled for 5%, but in our hearts, we believe that this is even lower. Probably lower than 2%, even more. So the thing is that we made models in order to try to describe to the audience ways of understanding, because in literature you're going to have 5, 10%, whatever, and we have the green one in 5%, the pink one is 10%, and when you overlap with the data that have been published is the blue one, so you can clearly see that probably it's less than 1%. The problem is that the groups become so small by the time you get to that 1% that it's very difficult to understand what kind of complication these patients have, and therefore makes research quite difficult. Therefore, the need for a definition. So 2023 was a great year for RIF because you had the ESHRE guidelines, clinical guidelines, and the Lugano consensus paper. They had different opinions. They have one thing in common. Professor Macklon was in both of them involved. So the thing is that the big difference between those two is that ESHRE guidelines are more focused on what clinicians should do in their practice and how to deal with patients who are coming asking you, what should I do? I failed it again and again. And the Lugano consensus, which was more focused on the defining and more like a definition for research to make sure that you have a cutoff of 95%, and with a focus on diagnosis, and the cutoff which ESHRE chose to use was 60%. Now, if you were to go back to this here, in order to understand what happens to this small population, or even here, to understand what happened in that population, you need to be very exigent with who are the population that you are looking into. Because as shown by 123,000 patients, by the time you end up with the last, you have less than 100 patients. So you need a big effort, so you need to apply a more exigent definition. So this is why it's important. So the two groups proposed quite similar kind of approaches. The Lugano, so because I work in France, we don't do PGTA here for reason related to law. But the thing is that we designed this model here, the Lugano consensus, with respect to the SART group of ages. And we tried to, with respect to the observed aneuploidy rates and the number of the embryos, euploid, needed to be transferred, to create a model for you to counsel your patients on how long the journey would be. Because, for example, as you can see here, if you remember at the beginning we said 3 embryo transfers. Now here, you see that 3 doesn't mean much for most patients. Even the population less than 35 needs 4 blastocysts, non-tested blastocysts, to achieve the 95% objective. And also, then it goes with age, and as you can see, a patient over 40 needs 13 to even 27 embryos to get to the first child, statistically. Now, Escher proposed some kind of model. The only place where I will be criticizing or challenging is the group of 35 to 39. The problem there is that the aneuploidy rate from 35 to 39 is so big, it's actually 30 to 50% almost, that a 39 patient cannot necessarily fit or overlap with a 35 patient or 36. Anyway, the thing is that things have been pushed forward. So you have, in 2023, you have received a new definitions for what you should apply to research. And this is very important. So I think that people should forget about the 2014 definitions and should focus on probably these two. There is a problem with the Escher guideline, and I hope Professor Macklon could help me out, is that the consistency of the 60%. Because it seems that it's shifting all the time. The 60%, it's never too high or too low, because you can see here, for example, in the group of 35, 3 is actually achieved at 67, 68, and then it's 59 for the group of 35, 39. And in terms of euploids, then you have 60% imposed, but they are overachieved from the first failure, but the recommendation is after the second one, which is actually 90, 87, and 82, which is much higher than the cutoff, minimal cutoff proposed. I only argue with this because if you would apply this to research, it would be very difficult to put a cutoff, because you see how it changes when you put a cutoff. So if you want a 60, 70 to 95, look how it can actually variate what actually failure represents. So this is very important, because the question is how exigent do you want to be with yourself, and what success looks to you. Is it looking like 100% or less? So this was the number of unscrewed embryos that Lugano consensus proposed. But the great thing is that both consensus papers agreed upon the fact that the add-ons do not have proof of efficacy at this point. So therefore, at least at this point, there was a common consensus that the add-ons that proposed, from anticoagulants, corticoids, antibiotics, not to mention the scratching. I mean, you've been in Escher, they talked about scratching even now. So the important thing is that there's a consensus on not to do all these things and others, which are not having show proof of efficacy. And the reason why I'm telling you is that recurrent implantation failure is how you explain to your patient to define their expectations. So, and I will give you an example. If you were to go back to Kiev or, I don't know, Estonia, and I'm telling you the flight will take you 1 hour. For 1 hour, you are gently seated in your seat, having your drink or looking at your iPhone, and you're not worried. And when you arrive, you arrive. But let's say I'm telling you it's 1 hour, and you are 3 hours in flight, you become anxious. You have anxiety and stress. What's happening? I want to know. So I think that the tables that I just showed you are very important for you to guide your patients in the journey of what IVF means. Because it's not like the patient fails the first embryo transfer and she comes in, doctor, why did it not work? Well, because it doesn't work all the time. So it's very important to define expectations with your patients, because the burden of dropout. So historically, dropout was something that people believed is related to the financial issues of IVF, because IVF is mostly on patients' pay, but in France it isn't. And this very nice paper actually showed that in a system where IVF is completely free, dropout is 22%. And it's quite high, probably it's the same in most countries, even when they have to pay. And it is because we fail to explain to the patients the journey in which they are embarking on. Okay? So this is extremely important. So you have to talk to your patients from day one what to expect with respect to age, at least. So my conclusions are that true RIF, unexplained RIF, is extremely uncommon, and in my point of view, not to be shocking, it occurs in less than 5% of the couples. Defining RIF needs a global effort. It needs European and Americans to get together because practices are quite different, and it could be that answering the question requires a global effort involving anyone that does IVF. I truly believe that reassurance and conventional treatments are warranted in most cases. We should not go overexcited and propose to patients things that have not been tested. I think it would seem reasonable not to assign the diagnosis of RIF to a patient unless she has failed 3 euploid embryo transfer or the equivalent number of untested embryos adjusted for the maternal age, because age is very important. Current add-ons should not be used, and they have no justification unless they prove efficacy that they work. So I don't think you should use things or test things on your patients like in a clinical setup. For research, definitely you could do it, but that's a different story. And I think my message, which is the strongest one, would be that probably the workup that you do from day one before transferring the first embryo should be the most complete one you can do. Why? Because it will strengthen the relationship of confidence with your patients, because when they will fail, you cannot say, well, now we're going to do something else. We're going to do a hysteroscopy. Do it the first time you can see the patient. Not wait for one failure to justify the use of a diagnostic before that, and so forth. So just usually with increasing embryo transfer, your patient will have higher likelihood of succeeding, and it should be that you have to address RIF with regard to age. That's extremely important. Thank you very much.
Thank you, Paul. I think that was really good. We'll invite Nick and Paul to sit here. You may have questions. I have a lot of questions, but you know what? What I like is in the final slide when you just put the workup, and it's clear. If you do not do a proper diagnosis of the soil, and you do not do a proper diagnosis of the seed, how can you expect to have a good result, right?
Yeah.
So I really love both talks. I think that there are going to be a lot of questions. So ask questions, okay? Well, we need microphones. If not, I need to share mine, okay?
Great. Thank you so much for both speakers for this deep dive into endometrial kingdom and to this big problem, recurrent implantation failure. I would like to address my first question to Professor Macklon. So will you be so pleased to give a comment on the recent studies regarding endometrial exosomes about the negative impact of these exosomes obtained from RIF patients on endometrial development, on euploid embryo development on animal models? So can we suggest in the nearest future that these tools like detecting of endometrial exosomes can be a diagnostic tool to prevent the implantation failure? And secondly, can we suggest that taking endometrial exosomes from healthy women, we can like transfer them and improve implantation in recurrent implantation failure group? Thank you so much.
Thank you. It's a very interesting area of research, and I think one of the most important papers that came out was from Carlos Simons, you'll be familiar, published in Development about 8 or 9 years ago, where they identified these exosomes being released by the endometrium prior to implantation, but when the embryo is in the uterus, and they demonstrated in a mouse model that these exosomes contain microRNA, which is taken up by the blastocyst and which can affect gene transcription in the blastocyst, which is really very interesting. And they also, and this was using mouse embryos in a human endometrial in vitro model. So since then, the field has moved on, and we've identified more things in these exosomes, as well as microRNA, but I personally think it's the RNAs where the future lies, because it's a very low bio, a small amount of material, and that's going to allow you to make more objective measurements. So I think it is important, and it's an exciting one. You can just take some endometrial fluid out. You probably don't even make a biopsy, and you can look in there. So watch that space. Now, the next question you say is, well, could we not take exosomes from a donor and put them in? So the reason I would say that's ethically becoming a little bit more difficult goes back to Carlos's paper, because it's not just around about a communication with the blastocyst and saying, come on, let's implant. It's actually maybe altering the blastocyst genetically as well. So we would need to be convinced in the human model, which is only now really being looked at, that this is not having some impact on the actual genetic, shall we say, the genes that get expressed. That's what it seems to be affecting, which genes get expressed, which is a very fascinating concept itself, that the endometrial environment is affecting which genes are expressed in the embryo. But that would be my slight ethical concern.
Mm-hmm.
Thank you very much.
That's a very good, case. And I have a couple of questions. Who else have questions here? Come on, don't be shy. You've never been shy before. Ask questions. Where? Okay. So one question, always the same. Do you have a microphone? Okay.
Thank you very much for your brilliant both presentations, and maybe I have a question for both of you. Just very short comment. Let's imagine very typical situation. We have a 41 years woman with very low anti-Müllerian AMH level, and we reach one euploid embryo during 1 year or maybe even more of trials. And are we gonna do more deep investigations of endometrium? I mean, not just the hysteroscopy, but maybe error test, I don't know, microbiota or whatever, before the transferring that euploid embryo. Thank you.
You want to go first? I will not do those. Because you don't have proof that works, and at 45, I mean, I will never have 45 years. 41? Yeah. 41? No, I will not do those. You are, no.
Okay, so let me ask you a question, okay? Because this is...
Before you do, I agree.
You do not do it?
No.
Okay, it's interesting because I've been in... The other day I was in a meeting with Canadians, and they were doing 46, and they're doing it. But the question, I have a question for you that is related with what you heard, which is, and it's related with the last thing that you put on your slide, which is... couple of things. First, if you talk about the embryo, we always talk about genetic normality, and as we all know, the genetic normality of the embryo is only one part of the whole structure, because almost, I would say, 95% of the cytoplasm of every cell of a blastocyst is coming from the oocyte, okay? So we never talk about cytoplasmic, with healthy. Don't you think that may have some effect on the final? You can have a normal genetic embryo, but the cytoplasm is not that normal, and you can have some effect on that 5% or whatever you talk about?
I think the answer's got to be yes, indeed. I mean, the embryo is far more than just the chromosomes. Otherwise, we would have 100% or 90% implantation.
So
each time.
why don't we concentrate more time on trying to define the cytoplasmic normality or healthy of an oocyte that's going to be part before, you know?
I think there's a couple of reasons for that. I mean, this is just my own view, and I'm not an embryologist, but I think partly there has been this huge focus on chromosomal health.
Yeah.
And that is where the technology and the investment's been made, and perhaps the companies see, you know, that that's a useful area to go. There has been quite a lot of work done on cytoplasmic health, and, you know, the difficulty is, you know, doing it in a way that's not going to affect the embryo. You'll remember Luca Gianaroli published some papers taking fluid from the blasted seal and analyzing that. The problem at that stage was that the analytic techniques didn't have a high enough resolution to really determine that. But it may well be that we go down that route. I think the more promising route actually is using NMR to look at the metabolomic spectrum, which will include all of these things. It's the downstream overall impact of the chromosomes, cytoplasmic health on the metabolic footprint of that embryo. And again, what we're beginning to do now is see evidence emerging that can actually be very predictive of embryo implantation. And of course, it has the advantage of being non-invasive. So I think that's probably more likely to be a route rather than analyzing the cytoplasm directly.
Paul, do you have something to say on that side?
I agree with what has been said. I think that's true. I think that the challenges come from the fact that also aneuploid implant. So it's quite tricky and this could be because of all the metabolisms that go aside. The problem is that they don't deliver, they don't get birth, but they also implant. So it could be that you should look into both aneuploid and euploid to really understand what is the pattern in the cytoplasm and so forth that actually creates implantation and success of implantation, whether they deliver or not. But I think that it's very difficult to do this in a human model.
Questions? Good. Microphone.
Thank you very much. I have one question to Professor Macklon. In your presentation, you showed that we can have miscarriage in women in two cases. First one, I tell about euploid embryo. The first one, when we do transfer a bit earlier, when, for example, endometrium has a big receptivity but low selectivity. And the second is the desalization, the low level of desalization, interference of the fertilization. So it seems rational to do the next embryo transfer, for example, one or few days later. For example, not on day 6 of progesterone, for example, on day 7 or 8 progesterone. What do you think about this clinical approach?
So thank you for that question, and it's a very good one. And it's one that, if you look at the paper by Jan Brosens recently, they're considering that might be a therapeutic intervention. That if decidulization is delayed, in other words, the development of the biosensor, which in a paper we published in Molecular Human Reproduction a few years ago, we think follows on from the window of receptivity. You then have this selectivity coming on. That there may be some patients where if by the time you put the embryo in, you've either missed that moment or it hasn't arrived yet. So what they're proposing, that with their test, one of the interventions may be that you actually personalize the time of embryo transfer so that the decidulization is optimal to nurture the good embryo and help reject the bad one. But we'll need clinical trials to assess that.
Okay. Thank you.
Can I just ask Christophe Blockeel to intervene? The question? Because they have done another trial showing that 5 days, 6 days, 7 days of progesterone doesn't change much.
Okay, a microphone from Christophe, please.
Very happy to intervene, but I did not get the question.
It was about the days of progesterone.
Yes, so we did 2 RCTs in our unit, and by the way, there's now the Turkish group who also added another paper to to that story. So what did we initially do? We transferred a day 3 embryo on the 3rd day or on the 5th day of the progesterone initiation. And what did we observe? That at the end of the day, the live birth rates were exactly the same. However, the miscarriage rates were significantly higher in the 3-day progesterone group as compared with a 5-day progesterone group. So maybe you could say that, well, the speculation was at that time that also aneuploid embryos or crab embryos would implant, the delayed embryos would implant that are genetically abnormal. But then we did a more interesting study, 5 days versus 7 days of progesterone in a blastocyst stage embryo transfer. Again, artificial cycle, artificially prepared cycle, and then on the 5th day or on the 7th day. And there we observed exactly the same results in both arms of the study. And the study was rejected in Human Reproduction, and I still am looking for the reviewers of that study who dared to reject that very nice study. And one of the commentaries was, guys, what are you doing? You are comparing 5 days with 7 days. It should be on the 6th day of the progesterone administration. And based on that comment, we said, it makes sense what they say. And we adapted our protocol to 6 days of progesterone instead of 5 or 7. We said, okay, let's go to 6. And then recently we have done a retrospective analysis looking at 5 days, 6 days or 7 days of progesterone administration prior to frozen embryo transfer, and the results were exactly the same.
So which one was the earlier one given a higher miscarriage? Sorry?
Then we are talking about day 3 embryo transfers,
okay.
not at the blastocyst stage. There was no difference in terms of miscarriages.
Perfect. You may have more questions. Another question right here.
Thank you, Christophe.
Thank you very much for a wonderful presentation. It's a huge work. And I have one question for both of speakers. Do you believe that trophoderm biopsy may reduce the implantation potential of euploid embryos? Thank you.
Shall I start on that one? Yeah. So there is a lot of data now, I think, that shows that the process of trophectoderm biopsy does not come at zero cost to the embryo, but it's a very small one. And some of the studies have suggested that we may lose around about 2% of embryos through that procedure. And that is a result of the refining of the procedure over the years. But it's going to be part of your consideration when you're thinking about doing PGTA, because it's likely that those embryos that have got poorer morphology are going to be less tolerant of that as well. So that 2% applies across the board, but if you've got a, I don't know, 4BC or something like that, you might take the view actually in that case, the risk to that embryo doesn't justify the benefit.
Mm-hmm. There's one question I have for Paul that is related again with your last line, which is, independently is 3, 5, 7, or whatever the percentage that is not having recurrent implantation failure with euploid embryos. And you just do the proper workout, okay? And instead of failing and then start trying things that are shoots in the dark, couldn't it be better if we just do more research or, trying to find out if microbiome is really affecting the whole thing? You just mentioned about immunological causes, and again, the other day I was in a meeting with Canadians, and they have a fight between one was saying, do we need to do immunological tests for every patient or not? And we have a specialist, an immunologist, that was basically going, yes, you need to do it. But then when I asked her, how many of the total cases that are being tested are really related with immunological causes? And she said 1 to 2%. And then she said the same thing that you mentioned. You need some immunological effect at the uterine environment to have implantation. So don't you think that we need to do the proper workout before, or the research that is being needed, that instead of shooting in the dark, we're going to say, look, before doing any transfer, this is a microbiome that you need to have. If you don't have it, it's not correct, okay? The immunological response needs to be at a certain level, like you just said, to have a proper implantation. You do not have a subclinical, you know what, endometriosis. So you have, endometrial infection, subclinical infection, you know what, or whatever, just to secure that all those causes are not related with the failure of implantation?
Well, I think the first step should be to know what a normal microbiota would look like.
Exactly.
And we don't.
No, but do the research. I'm saying doing the research, proper research just to get to that point.
I truly believe that proper research should be performed before any of this hits prime time. But the problem is that you cannot put 98% of the population that do IVF to do all the treatments for 1 or 2%. Because we cannot estimate that immunological problems arrive to all the population and do IVF. Yeah, definitely there are people, definitely there are patients who have problems. Definitely. The only thing we were saying at the beginning was that they're persistent and that the uterus can fix itself at some point in a way or another. But I don't think it's feasible to say all population of IVF should do this, that, and that before going forward, because it will be...
No. You didn't understand my question.
I'm sorry.
If you want to do a treatment, you need to have a proper diagnosis.
Exactly.
Right?
Yeah.
So it needs to make sense that if you want to put an embryo that is euploid, that you know that if you put 3 or 5 or whatever, you're going to have 95%. You want to avoid that 5%, you want to avoid it. Yeah. So you need to know that wherever you put it, all the things that could be related with a failure were, you know what, in a way defined with the proper research and know that may be a cause, and then do the proper workup before doing that. That's what I was saying.
Yes, but we don't know yet how this microbiome should look like.
No, I still didn't get it. Do the research. Did you get it?
To the bigger point that you make, which I completely agree with.
Yeah.
The problem why we are still in this impasse with recurrent implantation failure is because we've treated it as a medical diagnosis rather than a clinical experience.
Yeah.
And you see that. You see well-designed, randomized controlled trials where no attempt has been made at trying to understand what the causes are. Right. They just said, here's a group of patients who haven't conceived after 3 embryo transfers. We're going to randomize them to have heparin or not heparin, or scratch.
Exactly.
That's a good example.
Exactly.
Or the scratch. And no effort has been made, and I don't blame them because the tests are not there, as you said. But as the tests become available, before we do these interventions, we need to say, well, what is the rationale for the intervention here beyond just the clinical experience of recurrent implantation failure? We make a diagnosis, and then we test an intervention to treat the underlying cause that has been suggested by the diagnosis. Only then are we going to be able to move on. If we don't do that, in 10 years' time, we're going to be saying exactly the same thing. Nothing works.
Yeah.
But it may be that some things work in some patients, and that's what we've got to discern.
Sorry, Paul, maybe my Argentinian English is not that good, okay? But questions from the audience. If you do not speak good English like myself, it's not a problem. Speak in your language, and then someone is going to translate it, okay?
There is a question here.
Yeah, I have this question. A few years ago, there were reports about the ongoing study of leukemia inhibiting factor aiming to increase the implantation rate, and then these studies have been dropped. Do you know actually the outcome, the potential of studying also other pharmaceutical agents in order to increase the implantation rate?
I can answer that one, I think.
Yeah.
Also, go first, maybe. So, LIF was a big hope 15 years ago, and I think Diego will know the story of this one very well.
We used to have
but it was based, the salutary tale, because we shouldn't use the mouse as the model for managing women. Because the reason why LIF emerged, that there was a knockout mouse created for LIF, and no implantations occurred. And we moved too quickly to assuming, therefore, that this was a critical factor in implantation. Now, we now know it is a contributory factor, but it's not critical in the human. But the clinical trials were done. A lot of money was spent on developing recombinant LIF. on doing these trials, and they didn't show any benefit. And I think where the problem had just been making assumptions that the mouse is a good model for human implantation when it's not. Is that right, Diego?
Yeah. It was like when I joined the company 25 years ago, it was like the study was done at Bourne Hall. And, but don't you think that we did a mistake because we injected LIF instead of putting endometrial, intrauterine?
I don't think that would have rescued it, but it might with something else.
In any case, I have another question. This one for Paul is going to be, everyone is talking, you know, it's great. I love it. You know, we just got the patient say, well, you know what, if we get 3, you know what, euploid embryo transfers, it's fantastic. Or 4 or 5 or whatever, like they say, 130,000, 5, right? So, you can get to 95% live birth rate. But how easy it is to get 5 euploid blastocysts in a patient that is 39, 40, 41? No, you're not doing 41s, okay. How easy it is?
That's a very good question. I don't know. I don't know the answer. It's I think it's very variable to different patients.
Business issue.
Yes.
No, I mean, I don't know. It's something that it's so variable with each patient. Some will get from the first one. I mean, for example, I can give you actually another example. You can have a patient with 10 embryos, and you're going to transfer them one by one without knowing the genetic composition and so forth, and it could be the last one that will actually deliver.
Yeah.
And all the way down there, you went from prioritizing day 5s and you put day 6 at the end. You are transferring the most morphological normal embryos first. And it happens so often that the last one on the rack is the one that actually will deliver. So you don't even know. Some patients need 20 embryos to get to 1 euploid, some will need 2. It's impossible to predict, but I would rather guess that probably patients, for example in France, have 4 IVF reimbursed. And this average kind of like helps the most patients. They will eventually achieve at least 1 pregnancy in 4 IVF treatments. Now, how the French authorities managed to give this average, it beats me, I don't know, but it seems that most couples that have a real chance, excluding PGTA, okay, this is completely outside PGTA, they can get to babies if they get embryos. So
probably they didn't have more money to cover more cycles.
Usually a 5th one is acceptable if the doctor requires, so we can go up to 5 cycles. And those where you don't have embryos don't count.
Yeah, you want to say something?
The only thing is, you know, we actually agree on quite a lot. But I think there are some very valid questions that we both get challenged with, and one is around about this 95% versus 60%. And I think Paul actually articulated it very well. You know, ideally, for research, you want to have a very, very enriched population for recurrent implantation failure, where there's a real evidence of a substantial and indeed consistent issue. And 95%, I think, is justified by the data that he presents. The problem is indeed finding those populations. You know, if you look at the study the Gill study, where they went to 5 and 6, they had to look in 180,000 patients to identify the cohort. So in practical terms, it's going to be very difficult. And this was one of the considerations with the ESHRE guideline, as we said, well, where should we be? Should we be 95% or should we be 40%? Now, if you're at 95%, we felt, A, great for research, but difficult to find, and not reflecting clinical practice, because very few of our patients will have a 95% chance of conceiving.
Exactly.
So our version was, it has to be said, you know, a group's compromise, that's the way these things work when you're doing these guidelines, as to what people felt was a reasonable compromise between risking over-treatment, which is the risk when you go down, because you'll have people with a good prognosis who get labeled with recurrent implantation failure. And 60% was felt to be one that allowed a reasonable enriching for research, generate a population that you could find and which reflected the clinical reality. But from a biological point of view, of course, Paul's quite right.
Very good. Question?
Thank you for very excellent presentation, both of speakers. And I have one question for Paul. I like your opinion that it's very important to check everything before embryo transfer, before first embryo transfer.
Everything we can.
Yes. And what do you think about what's the most important?
What is a test very important before, during first
application test? What's the test? You show about immunologist test and immunohistochemical test, CD58 and
138.
Yes. What do you think about it?
I mean, it could be that hysteroscopy is a very big discussion point because hysteroscopy is performed differently across the world. For example, in some countries, patients will go into complete anesthesia to do the test, and it costs a lot of money. In France, we do it in 5 minutes with no anesthesia, and it's very cheap. Yeah, it's like 60 euros, but the Americans will tell you it's $1,000.
Yeah.
So the point of discord, it starts there with hysteroscopy. On everything else, most people agree that you have to do the workup for infertility, but they don't agree on hysteroscopy. Maybe in the future, karyotyping would be interesting to perform to both patients and the couple. But I think that nowadays, with respect to endometrial factor, hysteroscopy should be performed before the first embryo transfer, because now we are addressing the endometrial factor. When you talk about everything else, you can go very wide, and maybe whole X, I don't know, maybe people will propose things in the future to try to at least counsel patients who can have a reproductive failure issue genetic-wise acquired.
I mean, I think I agree with that, but it's very much around about the context of which care is provided. You know, in a setting which I used to work in the Netherlands, it's very much like France, where people get basically free treatment.
Yeah.
It's very reasonable to do a hysteroscopy because the burden of proof of its benefit is financially quite low. You know, the patient's not going to be paying for it. In a setting which many of you will probably work in, which is private, where the patient is having to fund these tests, I think a more incremental approach is appropriate because you've got to weigh up, is it worth them spending, $1,000 on hysteroscopy or saving that for the next IVF cycle? And I would say where the evidence at the moment is, that's what I would advise them to do. If on the other hand, I just need to tick a box and say hysteroscopy and it'll be done, then why not? But it's very context specific.
Yeah.
Any other question? Yes. More questions right there.
One question. You said about 1, 2, 3, 4, 5 attempts of embryo transfer. What do you think? Doesn't matter or matter to change the type of cryo protocol? For example, when the first attempt was embryo transfer in ART cycle, yes, and we transfer euploid embryo, we don't receive pregnancy. We to do, for example, hysteroscopy, we had good endometrium. We are planning the next attempt. It's better to change type of preparation of endometrium, for example, the next cycle to do in natural cycle, modified natural cycle. Or it doesn't matter, we can try to do the same type of preparation of endometrium.
Well, thank you for this question. The thing is that the preparation of the endometrium should not be driven by failure. It should be driven by the type of the patient you have. For example, today you can even do natural cycles if your patient has regular cycles and so forth. So there is no proof today that by changing the way you do your endometrial preparation has an impact on outcomes. There is none. But you should not, I mean, in my opinion, this is only my opinion, I don't think you should change the preparation because your patient failed. Because the preparation of the endometrium protocol, its only target is to get you to that endometrial you want and to get you synchronized with the embryo. It's not to get you more pregnancies. You know what I mean?
Yes, thank you, but I'm interested about your each day practice, because I understand that the target is the same, but the hormonal profile, the secretion of endometrium, it's different. I understand we don't have the proof that this strategy could be positive, but I interested about your meaning about it and about your practice.
My practice?
Yes.
In our practice, probably we'll split between half and half with artificial natural cycles, natural modified. But it's just because in France, we don't do embryo transfers on the weekends. So therefore, it's quite tricky to go full natural modified, because then you're going to have many cycles that will be cancelled due to the fact that you cannot serve them. And also, the artificial cycle seems to be the easiest to perform because it's quite clear. Nowadays, with the rise of the natural cycle, you're going to find a nice editorial in FNS by Rick Paulson, that actually show that you have to be careful on how you use modified cycles, because the moment you start doing ACG, you're going to have a rise in progesterone. So in my practice, we do half-half, but it's very random. I mean, why patient change the protocol is not related to failure. It's related to patient convenience and also money-wise, because we are using lots of injectable progesterone, and this is not reimbursed by the French authorities. So therefore, patients have to, first of all, buy it and then inject it. So it creates an added cost and discomfort. But our way of seeing things in terms of preparation, it's that it's just for patient convenience and cost. It's not for increasing outcomes. Because if we would believe that one will be superior to the other, we would do so from the first embryo transfer.
I understand. Thank you. And Professor Macklon, your opinion about it?
Do you want to say something, right?
Yeah, no, just touching on what's just been said is so right. The problem is when you start changing your regimen after failure and it's not being done on any evidence that it's better, if it again doesn't work, then where does the patient go? And there starts being trust issues.
Yeah.
And one of the questions they'll say, well, why didn't you do that first?
Yeah.
So I think
exactly.
if you do change something, and we do change, it's got to be based on some rationale, something you've learned about the first cycle that didn't go optimally, which we know we can change by changing. But I really am against changing for the sake of change. So if we get data suggesting that natural cycle is better than HRT cycle in a certain group of patients, and to be honest, actually one or two papers are beginning to appear which suggest that might be the case, then it's very reasonable to do it. But then we have to ask the question why we didn't do that in the first place.
You need to trust on your system. If not, you add another variable, and it's exactly as being said by Nick, So I think there was a really good discussion, but we need to go for lunch. So you can sit closer to the speakers and ask the questions. We need to thank you.
Уважаемые коллеги, перед тем, как мы пойдем на ланч, я предлагаю сделать групповое фото, потому что у нас как раз сейчас
I would like
максимально...
to make a group photo because the number of the participants right now is maximum. Let us stay here, and the lunch will be until 13:50. Let's make a group photo right now.
Коллеги, мы продолжаем. Я думаю, что вы не услышали меня. Микрофон?
Okay, so we'll start again.
Уважаемые коллеги, одно организационное объявление. Когда у вас идет синхронный перевод в наушниках, пожалуйста, отрегулируйте громкость таким образом, чтобы было слышно только вам, потому что идет фон, ну то есть слишком большая громкость в наушнике, она выдает звук во внешнее пространство, наружу, и оно создает некоторое такое гул. Да, помехи для тех, кто слушает в оригинале. Спасибо большое.
Déjame ver. Ahí está mejor. ¿Ahí te molesta?
No, bien.
No, está bien.
Está bien, perfecto.
Dear colleagues, ladies and gentlemen, and now we have to start the next session of our meeting. And I think we have a very clear message from the first part. And as for me, this message is just check your initial workup to understand that you do everything you need to do and you do not do everything which is unnecessary. So the next step, take a look at your own results and check whether you have the same implantation, pregnancy and delivery rate as Paul's IVF lab has. And only after that, and after transfer of at least 2 euploid embryos, which approximately should give you about more than 60% of pregnancy and delivery rate, we need to start very evidence-based and balanced workup for recurrent implantation failure according to the best knowledge we have today for this problem, for this syndrome. I can say that it's syndrome because that's not the one symptom on one disease, and there could be many cases. And at this part, we can address 2 more very hot topics I can say, with the best speakers in the field, well-known practitioners and scientists, which definitely no need to present specially, on such hot topics as progesterone measurement and adjustment in HRT cycles, and can we do something with that, and can it have impact on the results in the frozen cycles? And this presentation will be done by Dr. Elena Labarta, who is really well known in this field. Elena, the floor is yours, please.
Thank you. Thank you for your kind introduction. I'm really happy to be here with all of you today in this interactive session because you have the opportunity to ask questions and to learn how we work nowadays based on science. And as it has been said before, we have been paying a lot of attention in the last years to the stimulation to increase the quality of the embryos, but we were not paying attention to the luteal phase. And this is what I'm going to talk about, because in the last 10 years, we have started to investigate much more about the management of the luteal phase based on serum progesterone levels, because before that moment we thought that measuring serum progesterone levels was not useful because they were not telling us how much progesterone was present in the uterus. But as you will see in this lecture, it is important to monitor serum progesterone levels in order to tailor and improve our luteal phase support. So, why talking about progesterone? Progesterone is the hormone of pregnancy. Obviously, if we blocked its function by giving mifepristone or its production by doing an early lutectomy, a miscarriage is almost inevitable. So without progesterone, pregnancy cannot be sustained. And this is because progesterone is essential for inducing the secretory transformation of the endometrium and a proper decidualization favoring embryo implantation. And on the other hand, it helps into the pregnancy maintenance thanks to the immunomodulatory effects that progesterone exerts. For this reason, it is so important to have adequate levels of progesterone both in the endometrium and in the uterus and in the bloodstream. But it seems that the amount of progesterone that reaches the uterus is needed for acquiring the endometrial receptivity, but much more importantly, we need high levels of progesterone in the bloodstream in order to maintain the pregnancy, thanks to the immunomodulatory effects. And it is interesting to point out that there is no linear relationship between endometrial and serum progesterone levels. So, obviously, if we can measure something, is to measure serum progesterone levels in the bloodstream. And for doing this, it is very important to do a proper luteal phase support. And in frozen embryo transfer cycles, the amount of exogenous progesterone that the patients need will depend on the type of endometrial preparation used, being higher in the artificial cycle, because in this case, there is lack of endogenous production of progesterone because we don't have a corpus luteum, and this is why we have to focus our attention on this scenario. Just in case, sorry. Having troubles with this. So let's start talking about HRT cycles. Why? Well, because they are still a common mode of endometrial preparation. Because we have seen, I'm going to move here because I can't see the slides. Because we have seen that monitoring luteal phase support by measuring serum progesterone levels is needed. Why? Because the levels of progesterone impact on the pregnancy outcome. Also, we will address that there are a lot of interpatient differences in the way they absorb progesterone. And finally, I will show you how personalization or individualization has proven to be effective in HRT cycles. Can you hear me well? Or the quality of the sound? Yeah, thank you. For many years, clinicians felt confident about the management of luteal phase support in HRT cycles because high doses of progesterone were given. Let's come back. Well, were given because we thought that if we were using vaginal progesterone, high amounts of progesterone were present in the uterus, and finally because we thought that serum progesterone levels were not predictive, but we were completely mistaken. In fact, since the year 2015, many studies started showing that there was a correlation between serum progesterone levels and pregnancy outcome. And there was a minimal threshold of progesterone that needed to be reached to optimize the outcome. And the results were striking. We had the honor to publish the first two prospective cohort blinded studies demonstrating that those patients with serum progesterone levels below a certain threshold on the day of embryo transfer had 18–20% lower ongoing pregnancy rate. And this was incredible because we were not paying attention to serum progesterone levels until that moment. And very importantly, you have to take into account that all these patients were receiving estrogens and then micronized vaginal progesterone at a dose of 400 milligrams every 12 hours. We considered that this dose was more than needed. So we cannot extrapolate the results of these studies to other routes or doses of progesterone. But we wanted to understand why there were so many differences in the serum progesterone concentrations in these patients. Many factors have been analyzed so far, but I would like to pay attention to the route of progesterone administration, because nowadays, obviously, after these studies, you have started, or many clinicians have started measuring serum progesterone levels. But then you have to know how to interpret the results. And this is going to be different according to the route of progesterone given, because the pharmacokinetics is completely different. And you will show this in the next slide. Let me show you these preliminary results of a pharmacokinetic study that we are conducting right now, comparing different routes of progesterone administration in artificial cycles versus the natural cycle, true natural cycle as the gold standard. And as you can see, the artificial cycles with vaginal progesterone show a pattern of progesterone levels throughout the day, more similar to the natural cycle, more stable, and lower levels in comparison to all these patients receiving a parenteral route. So look at this. After the injection of progesterone, either intramuscular or subcutaneous, you have a peak immediately after this injection, 1 or 2 hours later, and patients do not reach steady levels until 6 or more hours later. This is something that it was expected. But this means that if we want to measure serum progesterone levels in order to know if the patient is being exposed to adequate levels, we should wait until a steady level. So it is not recommended to measure serum progesterone levels very close to the last insertion of progesterone. So it's just to take this into account, because many papers are appearing now measuring serum progesterone levels after parenteral administration, but if you don't, or if you are not systematic at the moment on measuring this, you can be misinterpreting the results. Another important factor is the body mass index, because systematically we and other groups have seen that the higher the BMI, the greater the likelihood of having suboptimal levels of progesterone. So this should be taken into account when considering the dose to obese patients. And a very interesting study that we have conducted is that we have tried to analyze if the vaginal dysbiosis or vaginal microbiome could impact on the progesterone uptake. Because our hypothesis was that perhaps if the vaginal conditions were not optimal, or the pH, this could influence on the capacity of absorption of progesterone. And very interestingly, we have found that those patients with a non-lactobacillus dominant profile had a significantly lower mean serum progesterone level on the day of embryo transfer in comparison with patients with an eubiosis. And interestingly, the percentage of patients with inadequate progesterone, with progesterone levels below our critical cutoff, was significantly higher. So this opens a new line of research about, well, what to do in these cases if the solution is to change the route of progesterone to treat this, or try to give directly more doses from the beginning. The most important message is that we and others have seen systematically that around 30–40% of the patients receiving vaginal progesterone in artificial cycles were below the optimal cutoff or the optimal threshold. And this is why we tried to see if we could rescue this situation at the moment of embryo transfer in order to avoid canceling that cycle once we were aware of the negative impact of having low levels of progesterone. Unfortunately, well, we have demonstrated that it works. But for doing this, the recommendation is to monitor serum progesterone levels, ideally 6 hours after the last exogenous progesterone administration, and then do this rescue therapy. And you can see here how this strategy is effective. We compare the results of patients with low progesterone levels on the day of embryo transfer and receiving an extra injection of subcutaneous progesterone from that day onwards in comparison to those patients with normal levels with vaginal progesterone. And as you can see here, there were no longer differences. So this means that the rescue treatment proves to be effective, and we don't need to start with more or higher doses of progesterone from the beginning. We can add an extra dose of progesterone only in those patients who need a support, which is around 30%. This rescue treatment can be done also with another routes, okay? We tried with the subcutaneous route, but for example, the group of Alsberg tried the rectal route, and they have demonstrated that it is also effective. And also the Brussels group have done this with the addition of oral dydrogesterone, and also they observed that this strategy is effective. So at the end, the key message is, if you are not having adequate levels of progesterone with one route, with the vaginal route, the solution does not seem to increase the dose of vaginal progesterone, because there is like a limit of absorption. You should add another route of progesterone administration to compensate this. And this has been clearly demonstrated in this meta-analysis. So just to finish this part, talking about HRT cycles, we can say that at the beginning we detected a problem. We were not aware of that 10 years ago, and we observed that a critical cutoff of serum progesterone levels was detected in our house. Our cutoff is around 9 nanograms per ml. In many centers, they have chosen the cutoff of 10 nanograms per ml because they say it is easier to remember. Okay, it's close to nature. Levels of progesterone have to be between 9 and 10, and ongoing pregnancy rates decreased below that threshold. Once we detected this problem, we were aware of the high prevalence, 30%. I have to say that nowadays we have decreased the percentage of patients with inadequate levels of progesterone by receiving only vaginal progesterone. Why? Because we are more strict on the way of administering progesterone. Some years ago, we said, okay, just put a capsule in the morning, one at night, no matter the moment of the day. It's not necessary to receive this every 12 hours, and now we are more strict once we have seen that there are some circadian variations throughout the day because of the time of progesterone exposure. We have detected some risk factors for having these low levels of progesterone, and we have found a solution. So fortunately, we know nowadays how to manage the artificial cycle, the luteal phase support in the artificial cycle by using a rescue therapy. The dilemma is that perhaps we are giving too much medication. I mean, we are going from the beginning to a medicated cycle. We realize that iatrogenically we have cases with low levels of progesterone. We know how to treat this, but this means that we need to give extra doses of progesterone. So obviously we have solved the situation, but this means that the patients are being exposed to very high doses of medication. So which is the future? Well, as you will see now, we should perhaps consider the option of moving to a natural approach, and in case of needing to do an artificial cycle or to consider an artificial cycle, we should stratify the patients to calculate the risk of having low levels of progesterone or even for having obstetrical complications. So I think that we should do nowadays a more individualized approach to decide if doing an artificial cycle or not. And now let's move to the natural cycle. Why talking about this? Because They are becoming more popular nowadays. Regarding the luteal phase support, there is a little bit controversy about the needing or not of adding luteal phase support, but what it is clear is that if progesterone levels are low, they are going to impact on the final outcome as expected. There are interpatient differences, yes, as you will see in the next slides. Many patients under a true natural cycles can show a luteal phase deficiency, and this is why it is important also to pay attention to the management of luteal phase support in natural cycles. And the personalization, as you will see, is also effective in this scenario. We can choose to do a true or a pure natural cycle guided by the LH peak and without any luteal phase support, or a modified natural cycle with ACG for triggering. When doing a modified natural cycle with an ACG trigger, the group of Brussels have demonstrated that measuring serum progesterone is a little bit challenging because there are some variations, circadian variations throughout the day, being a little bit lower in the afternoon, but at the end, they do not seem to be so clinically important. Why? Because we and another group have observed that when using ACG for trigger in natural cycles, the levels of progesterone do not seem to predict or be related with the ongoing pregnancy rate, regardless the use of luteal phase support or not. So once you use ACG for trigger, perhaps the hypothesis is that this injection of ACG may activate the corpus luteum in the middle late luteal phase, producing more progesterone, and perhaps we could even skip the needing of giving a luteal phase support. So at the end, when we use ACG for trigger, we ensure high levels of progesterone, and perhaps it is not needed to measure serum progesterone levels because they have not been correlated with the pregnancy outcome. Why? Because most of the patients have adequate levels. On the contrary, in the true natural cycle, in which measuring serum progesterone levels is even more challenging because of the circadian variations of progesterone, it has been seen that those patients with a luteal phase deficiency, which means having serum progesterone levels below 10 nanograms per ml, have a significantly poorer pregnancy outcome as expected. But the most important message here is that it has been seen that 1 out of 3 infertile patients show inadequate levels of progesterone. This is higher than initially thought, probably because we are dealing with an infertile population. And this can explain why perhaps when adding luteal phase support to a true natural cycle, the results are improved, perhaps because you are covering these patients with a luteal phase deficiency. So what are the management options in natural cycles? Well, one could be to add luteal phase support in cases in which we detect a luteal phase defect. In fact, it has been demonstrated that the rescue treatment is effective. But this is very, very difficult because it implies that we need to measure serum progesterone levels, and because of the circadian variations in a natural cycle, we should do this more than once per day, ideally 2 or 3 times, and this is not practical. So this is why another option, perhaps safer and more convenient, could be to consider the option of switching to a modified natural cycle with ACG, with or without luteal phase support, with the advantage of not needing measuring serum progesterone levels because high levels of progesterone are achieved, adequate pregnancy rates are observed, and this gives you also the option of moving a little bit the day of embryo transfer. So you have more flexibility when scheduling the embryo transfer, as you will see in the next slide. In fact, many doctors have been reluctant to do natural cycles until now because they were afraid of not being able to schedule the moment of the embryo transfer. And this is one of the reasons why we have been doing artificial cycles during the last years, perhaps more than ideally needed, okay, because it was easier for our agenda. But fortunately nowadays there are like novel natural cycle approaches which are based on the concept that perhaps we should not forget, but perhaps pay less attention to the size of the follicle, because they need a follicle but not to obtain a mature oocyte, and with the idea that the important thing is to obtain a good endometrial thickness. So one approach is to trigger with ACG, so this means to do a modified natural cycle once the endometrium is greater than 7 millimeters and we see a follicle of a minimum of 13 millimeters. The group of Madrid has published that there are no differences in results regardless the size of the follicles, and that this approach gives you the advantage of having a greater flexibility to schedule the moment of the embryo transfer. Obviously, as discussing with Dr. Blockeel the other day, we don't know if this follicle will be or will have the same capacity to protect against preeclampsia or because of the relaxin production. This has to be addressed. But regarding pregnancy outcomes, there seems to be similar regardless the size of the follicle. So this is very convenient nowadays. And the other option is the so-called natural proliferative phase frozen embryo transfer. What does it mean? In this case, once the endometrium has reached 7 millimeters and you see a follicle of 14 millimeters as minimum, you can start directly the luteal phase support without giving the ACG injection. You give more progesterone than in the other approach because you are giving the same dose as in an artificial cycle. But this approach allows the follicle to continue growing, and finally they have seen that in 80% of the cases they finally ovulate by themselves. So you have the two advantages. On one hand, you have a corpus luteum producing relaxin and probably protecting from the risk of preeclampsia, or at least decreasing the risk of preeclampsia, and you have the advantage of being able to schedule the moment of the embryo transfer because it will depend on the onset of exogenous progesterone. So these two approaches allow us to use more natural cycles, and I think that this is where we should be nowadays. Why? Because nowadays we are aware of the risk of having a high risk of preeclampsia in artificial cycles. It is true that this has yet to be clearly demonstrated, but it is logical to think that if we can choose for a more physiological approach, it is better from the beginning. So it's just to learn how to do it well. So just to finish the lessons learned from our research in natural cycles, we have to point out that the luteal phase insufficiency exists in true natural cycles, and patients with low levels of progesterone have lower chances of pregnancy. And this happens in 30% of the cases. The solution is to individualize the luteal phase also in natural cycles, just by adding progesterone to those patients who need this, or just by moving directly to a modified natural cycle. And the future, as I said before, let's try to switch to natural cycle when possible, and obviously the use of novel approaches will open this possibility to program more cycles in this setting. Thank you so much for your attention.
Thank you so much, Dr. Labarta, for your excellent presentation. And it seems it's so practical. So I believe that with this approach we could change our practice and to rescue some luteal phases and allow some embryos, some euploid embryos to implant. In that case, which without this luteal phase support adjustment, it could not. So we will have time to Q&A session after the second presentation. So yes, we're moving forward. And the next speaker is a very good friend of mine and a very good friend of Ukraine and very supportive person who also is very well-known scientist and extremely extensively published person in this field. And the next hot topic, I think it's very hot because obesity becomes really epidemic in the model world. So it might be, it can impact infertility and fertility treatment results. Christophe, the floor is yours.
Thank you very much, Mikola. Thank you so much for the kind words of introduction, and obviously, you know that the family of the Grishenkos have a special place in our hearts. And I also would like to congratulate you, Mr. Chairman, with this very beautiful sign, because do you know who created this? It is Mykola Grishenko who has made this. It is your favorite thing to do in your free time, apparently. So congratulations for that. Dear ladies and gentlemen, I hope you had a good lunch, because now let's stop eating, because let's see what it can cause and what it can give. Because as, these are my disclosures, but probably the most important disclosure is that I really like and love good food, and sometimes also bad food. So, so this is the major disclosure. We have a problem, and as Mikola just told us, there is the pandemic of the overweight, because are you aware that 53%, according to the new data of the WHO, are suffering from overweight, meaning a BMI of above 25. So we really need to do something, not only as a fertility society, but generally this is problematic, obviously. But let us first have a look at the spontaneous conception prior to go to IVF. Is there a problem with obesity? Well, yes, because it will cause chronic inflammation, insulin resistance. The oxidative stress is probably important for the decreased quality at the level of the oocytes and the embryos, which will cause a dysmetabolic infertility at the end of the day. So we are not doing well there. There is an association between BMI and subfertility. This is the so-called J-shaped curves, both for women and for men, in which you can see that increasing body mass index have a deleterious impact. But also underweight needs to be acknowledged, because there also you have an increased chance of having subfertility, both in men and in women. This is a very large cohort from our colleagues from Norway. With regard to spontaneous conception, let's not only look at the woman, let's not only look at the man, but let us have a look at a couple. And I'm quite convinced that now you see a couple of patients or couples in front of you. Did you know that not only an obese woman together with an obese man can be deleterious or have a decreased chance of achieving a pregnancy, but also the obese woman with the skinny man sitting next to his wife is actually the worst strategy that you can have. In other words, this is another study that confirms that, a huge series of patients. So you have the so-called the fecundability odds ratio, the combination of an obese woman with an a skinny man is actually the worst combination, as you can observe in this graph. So we have to take this into account. Miscarriage rates are increased. Miscarriage rates are increased, again, not only in the overweight and extreme overweight, but also in patients suffering from underweight. There is enough evidence and meta-analysis showing the significance in terms of this outcome parameter. It is not only pathophysiology, it's not only hard data, but also the psychological effect plays a role. We do know very well that the sexual function is decreased in an obese woman. The self-esteem of the self-image of the woman decreases with increased BMI, and obviously you want to be attractive, which will maybe lead to intercourse. Well, if there is a decreased self-image, there will be less intercourse and diminished conception. This is the man, and we do know that DNA fragmentation will be increased at the level of the sperm quality. We know that chronic inflammation and abnormal levels of adipokines are deleterious for the sperm quality. There is a very nice and elegant review by Andrew Peel in Andrology of 2023. And by the way, there is another paper, a very nice meta-analysis, 29 studies showing the same, that when looking at the waist circumference of the man, obese man will have decreased concentration, decreased motility, and decreased morphology of their spermiogram. So important findings also for the male. But of course we are fertility doctors. Let's solve the issue by doing IVF. Maybe we are able to circumvent the whole story. But it is not true. And this is a very simple graph that we all have in our consultation boxes. It is a cohort performed by Anja Pinborg from Denmark, a cohort 1,400 patients who were looked at, and obviously the age of the female is the most important predictive factor. We all know that chances of achieving a pregnancy will decrease with age, but also with increased BMI. There is the so-called BMI optimum in terms of number of embryos. So again, with increasing body weight, we will have less available embryos. But also, have a look at the underweight. There is this so-called BMI optimum between 20 and around 25, let's say. What about obesity and live birth rates when talking about our specialty ART or IVF? Well, a meta-analysis has been published, 21 studies, another meta-analysis has been published, and again, not only miscarriage rates will spectacularly increase with increased body weight, but also the live birth rates will decrease significantly in patients with morbid obesity, as you can see. Here, you cannot see it, but the BMI goes even until 50. And talking about 50 of BMI, let's go to the United States, because they are more royal, let's say, they are more open to treat people with overweight and obesity. In the States, this is the SART data, so the data from the US, showing that with increasing BMI, you will have live birth rates shrinking and going down, decreasing quite spectacularly. So important findings are here. An analysis of 239,000 IVF cycles, quite spectacular to see how implantation rates, clinical pregnancy rates, and live birth rates decrease.
What is going on and what is behind this whole story? Do we have an issue at the level of the oocyte, the embryo, or is it the endometrium? Because when we look, for example, at studies looking at PGT, we do not see an increased rate of aneuploidy between the obese and the non-obese. At the level of the blastocyst formation, so morphokinetic studies have been performed, we don't see so much of a difference there. So the question is, do we still need to look into the epigenetic, in the mitochondrial oocyte quality to assess whether there is a difference there, or should we more concentrate on the endometrium? And is it the implantation potential that is altered because of the inflammatory environment? This is, of course, a question, but an interesting population to study this is the oocyte donation. So let us have a look at recipients with increasing BMI. So the oocytes are coming from oocyte donors, ideal situation to assess whether it comes from oocytes or embryos, but have a look. When looking at increasing BMIs in the recipients, we also observe lower ongoing pregnancy rates and live birth rates in the patients. So obviously we see that the levels are decreasing, so probably it is a combination of both strategies, but especially here the endometrium will play a role in the whole story of having decreased numbers in patients suffering from obesity. What about when having PGT patients? So we have all the PGT cycles gathered together in this Peterson study, 2023 in FNS. We are talking about 77,000 PGTA cycles, while the predicted probability of live birth is also at a certain optimum of the BMI. So this is aneuploidy tested patients, and we have talked about that in the earlier lectures, but again, there is an impact at this stage as well. So at least let us give some attention to this story. And I could continue with large series. Let's hear the Kluge study, also from the Nordic countries, 126,000 fresh cycles, and subsequent frozen embryo transfers. Also there, the cumulative live birth rates are decreasing significantly with increasing BMI. Except for the States. In the States, they say, well, if we look at the different categories of BMI, we do not have such a big problem with patients suffering from infertility or suffering from lower ongoing pregnancy rates and live birth rates. But if we look a little bit into detail to this study, their reference in the States is a BMI of 30 to 35. This is the reference. For us, sorry, but this is already quite overweight. And of course, if you then are going to compare with your reference of a BMI of 35, then obviously, and fortunately, there are not so many patients in the 50 plus, but they say as soon as you have a good antenatal care, a good neonatologist, a very nice anesthesiologist who can assist you with the C-section, everything is more or less under control. Do you know that a patient with a BMI of more than 50 can hardly walk because of the obesity? So this is something to take into account. And they are happy with their figures of 64% of C-section, labor induction of 40%, preeclampsia is also very high, postpartum hemorrhage and preterm birth. Is this what we should strive for? I'm not convinced that this is the way forward to go. very nice study from Santos Ribeiro. First author was Rafael from the EV group in Lisbon, who said, well, do not forget age, because age is indeed the most important predictive factor. And the gain that you have in older patients is really marginal when losing, let's say, 2 points, 3 points of BMI. Yes, do invest in young patients, because when you lower the BMI in a 34-year-old patient, and you can lower the BMI with, let's say, 5 points, then it will have an impact on live birth rates. So with this model, you can very nicely see at until what age you can invest in trying to make your patient in a safer way to obtain her pregnancy. And again, so we have talked about the male in the spontaneous conception, but also the male in the IVF setting has been proven that the paternal BMI also plays a role in terms of the percentage, for example, of fertilization rate. A male obese probably plays a role there. There is no very hard data to show it at the level of live birth rates with paternal BMI and a combination of IVF, but fertilization rates are significantly decreased in increasing BMI. What about underweight? Because we have been spoken about overweight, and this is probably also more important in terms of incidence, but underweight is also quite an important player. And again, Pinborg, you saw that number of embryos will also decrease, but obviously, according to the literature, we do know that there will be an increased risk of miscarriage, there will be an increased risk of extrauterine gravidity, of small for gestational age babies, and also lower outcomes. So we also need to focus on those patients with underweight, although the literature is a bit conflicting here, because let's refer again to the paper of Santos Ribeiro, who was the last author in the, from the EV group. They said, well, we cannot show that patients with a BMI below 18.5 do have a lower chance of having a live birth following IVF. Where does this discrepancy come from? When you say, well, some papers say underweight is a problem, here it is not a problem. Well, I would like you to, this is the message for today, instead of looking at BMI only, we should have a look at the body composition. And let me give the example of this patient. 3 different patients with the same BMI, 17.5 of BMI. But the first one is a constitutional lean person. She eats as it should be. She has a balanced nutrition and she has a normal body composition. Of course, at the lower end of the fat mass, at the lower end of the muscle mass, but she has a normal body composition. Whereas this is the so-called marathon runner, an athlete. She has a decreased muscle, a decreased fat mass, very low fat mass, but a normal or even increased muscle mass. And then you have the problematic group of patients. It's also, fortunately, a less frequent group of patients, but around 10% of those low BMIs are really the malnutrition patients who have a decreased fat mass and also decreased fat-free mass, so a decreased muscle mass. And this is the problematic number of people that we see at the clinic. Those patients should not get pregnant before they get treated, at least by a nutritionist, psychologist, and so on. So please be aware of this category of patients. We could even do an MRI to look at the body composition. And you see here two patients with a BMI of 29. You see here Serena Williams, and here another patient with a BMI of 29. This is all muscle mass. This is all muscle mass, or an increased muscle mass, let's say. This is a lot of fat mass. Sometimes we see people who are around 50% based on fat. So 50 kgs or 55 kgs of fat. Can you imagine? This is what we sometimes see at the outpatient clinic in our unit. But the difference between these both patients is amazing and is crucial in terms of outcomes for their IVF treatment and for the quality of oocytes and embryos. And this is why we have recently written a paper that I would really encourage you to read. Let us forget about BMI. And I know it is an easy tool in the clinic. You just ask the patient. Of course, she needs to answer correctly, so maybe put her on the scale. But let's go to body composition instead of body mass index. Sorry. What can we do now? We have this obese patient or couple sitting in front of us. What are we going to do? Well, first of all, we know that as a fertility physician, that in 33% of the cases, we will not start, especially in Europe, we will not start treatment because of morbid obesity. For example, in our unit, if the BMI is above 35, which means morbid obesity, we will not start ovarian stimulation, probably mostly because of the obstetric complications. There's real evidence there, rather than the decreased outcomes of the fertility. But the patients themselves, they also are extremely interested in knowing, what can we do ourselves, doctor? What can we do? And then it comes on the fourth place or the third place. What is the impact of eating this or that on my fertility, on my success to get pregnant? So the patients are really motivated to do something on their nutrition, on their diet. And this is, of course, a very nice thing to have. This was based on a survey that was distributed in 2,000 patients, multi-center study in 8 countries. And then, of course, the crowd goes wild. There has been a hype about weight, about the impact of weight loss. Does it really matter when you lose weight or not? And quite some studies have been performed in the past and in more recent years to see what the impact was. Diet and exercise, diet only, or exercise only. And the results of these studies, quite some nice studies, published in for example, New England Journal of Medicine and Lancet papers, most of the time, those studies were quite negative. Negative studies showing not really an impact on pregnancy rates, on live birth rates, when comparing the two groups with intervention and without intervention. So, for example, the Einarsson paper from our colleagues in the Scandinavian countries, they said, well, whether you do a weight reduction prior to IVF or IVF immediately, you don't see a significant difference. So is it worth the case? But of course you need to read the paper very carefully, because if you look at the spontaneous conception in the weight loss group, this was significantly higher as compared with the IVF only group. So sometimes you do not need of course, we don't like to hear that we don't need IVF anymore, that they get pregnant spontaneously, but obviously this is an important measure as well. But probably the most important reason why the studies do not really show a benefit of exercise, of diet, is because of the fact that putting patients into starvation and giving them shakes during 1 month, for example, or 2 months or 3 months, of course they will lose weight, but this is not what we want. This is the so-called unhealthy weight loss. Putting them in starvation can also have a deleterious impact on metabolism, on oxidative stress, on inflammation, and on oocyte and embryo quality. So this is what we should not strive for. So we are more for the, let's say, sustainable weight loss, And this is why together with Elisabeth de Waele from the Fertility and Metabolism Clinic, we created a clinical project and also a research project, the so-called FERMET Clinic, so Fertility and Metabolism Clinic. And what do we do? Well, 3 things. We say, okay, let's do a bioimpedance assessment. What is that? Well, it's actually an instrument not so expensive that you can easily apply in your daily clinical practice, and it actually will give us in a couple of minutes what your fat mass is, what your free fat mass is, and your muscle mass. So this is very interesting. It's just 2 points of probes, and then after a while you have the result. Then you have the indirect calorimetry coming from the intensive care unit, in which your resting energy expenditure is assessed. We come back to that immediately, and then also the patients are asked to give their food diary analysis to assess or to list what they actually eat, because sometimes we need to say, flies, let's eat it, proteins. We sometimes need to say to the patient, well, doctor, I don't eat a lot. I only eat 2 donuts as a breakfast and then nothing during the day. 2 donuts as a breakfast, of course, this is not okay. But sometimes patients are not aware what a balanced nutritional intake can mean. So an example. This microphone is making me nervous. The BIA assessment, so the bioelectric impedance. The bioelectric impedance, what is it? Well, for example, this is an example of an underweight patient. She has a BMI of 16, so 16.4. So very important to see what her fat mass is, what her fat-free mass is. And here, so you know that around, 18% of the mass should be fat mass. Here you see 4 kilograms of fat. This is not okay. This is a complete and malnourished, malnutrition patient. So she needs to be helped to try to fix this. Just an example of a patient case of body composition. Then we go to the resting energy expenditure. The resting energy expenditure. So you have a kind of a bowl during 8 minutes, a bowl or a couplet around you, and then the oxygen that you will take in, and the CO2 that will get out. So the VO2 and the VCO2 is combined, and this will give you a number. So for example, here she has a resting expenditure of 1700 kcal. So that means that when she doesn't move, just surviving, she will consume 1,700 kilocalories. So if you take some movements into account, that will increase with a couple of hundreds of calories. So if this patient wants to lose weight, she will need, let's say, 1,700, 800 calories as an intake. If this patient, of course, she needs to increase her weight, so she will have to take around 2,500 kcal in order to increase her body weight. So this is how the calorimetry is assessed by our nutrition specialist. But it all comes to this. We are not doing well, and we are so happy with this Western diet. And I was looking during lunch, of course this was an exclusive lunch, but we have too many processed foods. We have too much bad food that gives us an increased inflammation. We should actually change to the non-inflammatory, or at least a reduction of the inflammatory nutrition that we take to us. We should, of course, have a very nice balance and eat mostly fruit and vegetables, except the things that we like most. So meat should only be, well, let's say a couple of times per week. We don't do that. Red meat and sweets is of course not okay in terms of the nutrition. I'm not a nutritionist, obviously, but we have people to help us and to try to guide our patients to have a balanced nutritional intake. But this is something else. And recently a student did the analysis in 164 patients, and she assessed both in underweight and in overweight what the physical activity was. And as you can observe there, 40% of the people did not have any physical activity. So this is also a major drawback. And then 34% was saying they have one activity, but one activity can also mean walking for, let's say, half an hour. So whether this is really an activity can be questions, but just to tell you that the lack of physical activity is certainly also an issue. So two important things: nutritional intake and physical activity. And with this, ladies and gentlemen, I would like to say, please, we know the association between obesity on one hand and decreased reproductive outcomes on the other hand. We know that there's probably an issue at the level of the oocyte and also the endometrium. What I would like to bring you as a message is, please let us maybe go away from BMI and take body composition as the primary drive to assess the patients and to counsel them in terms of adequate nutrition and also adequate physical activity. Thank you very much indeed.
Professor Blockeel, Dr. Labarta, thank you very much for your wonderful presentations. And now we have time for questions and answers. And please, I invited you to the stage. And so, okay, I can see hands. Let's start from the first. She was fastest.
Thanks a lot, both of us, for your great presentations. I want to know when you start progesterone, how many hours before embryo transfer, in the afternoon or in the evening?
That's a good question. We start at midday, because usually we do the...
It doesn't work.
It doesn't work, okay.
Yeah, that's
do
good.
you have to connect it, or? Okay.
Okay.
Okay, so we use this, yeah. So we did a study in which we compare on the day 0 when you start progesterone if there was any difference starting in the morning or in the evening. And we didn't see differences in terms of pregnancy rates. We only saw that those patients started in the morning
had a slightly percentage of risk of having low progesterone levels on the day of embryo transfer. But in terms of clinical outcome, it didn't impact. So at the end, this gives you flexibility. And obviously, this demonstrates that the window of implantation is not so close. So narrow, sorry.
Professor Blockeel, may I also ask you answer this question? Because, you know, in Brussels, it's more than 6,000 fresh cycles, and I think approximately the same number of frozen and fresh embryo transfers. So what do you think about the time of progesterone? Do you control these things?
Well, of course, when you have so many cycles, you need to work in strategies, and patients are called by the people of the monitoring unit during 2 p.m. and 8 p.m. So we said, okay, we will start in the morning following the telephone call, and then we do on the 6th day of progesterone, as I was telling you before, on the 6th day of progesterone in artificial cycles. So we start in the morning. Yeah.
Mm-hmm. On the 6th day, again, when you use three days.
Let's stress on the fact, as Elena said, the window of implantation. In the beginning, we thought it was this, and then we did the ERA test, and then ERA died, and the implantation, the window of implantation, is this. So we have some flexibility there.
But if you are talking about the implantation window, may I address you my personal question? You told in the first part of our meeting that you analyzed the results of transferring of 3 days embryo. I mean, on the stage of 8 cells, approximately, yeah?
Well, no, because I told you this on a 3-day embryo, but we thaw the 3-day embryo the day before.
Yes.
So actually, you have to say that it is a day 4 embryo.
Day 4.
That we replace on the 5th day of embryo transfer.
And the results?
Of course, this is more fast because today we do blastocyst stage embryo transfer in the vast majority of the cases.
So my question is, can we translate these results and try to move to the blastocyst stage and think about should we do the blastocyst stage transfer maybe a day later? Sorry? Blastocyst transfer. You transferred 4-day embryo the day later.
Yes.
1 day later after you started progesterone. But what about the blastocyst stage?
So the blastocyst stage embryo, if, for example, today is Wednesday, the patient did an ultrasound scan, a blood sample, everything is fine, the endometrium is more than 7 millimeters. We will hear from Dr. Ata what the ideal millimeter thickness is of the endometrium, and let's not start that discussion. But then, if it's today Wednesday, then we will introduce progesterone tomorrow, so Thursday, and on the 6th day, Thursday, Friday, Saturday, Sunday, Monday, and Tuesday will be the embryo transfer on the 6th day of progesterone administration.
Thank you. Dr. Labarta, can you please comment on this? Well, how are you doing it?
We do the same way.
Same way.
It's 5 complete days, which means that you have been receiving progesterone from 120 hours, more or less. With this flexibility that we were commenting.
Perfect, thank you. And we have many questions from audience.
Thank you very much for great presentation. I have a question to both speakers. Today, Elena Labarta and few months in Lisbon, Christophe Blockeel tell us about this novel approach. It means modify natural cycle when we don't wait, when follicle will 20 millimeters, yes. Or for example, we give HCG trigger when follicle is 14 millimeters and endometrium is 7 or more millimeters. But the big advantage of modified natural cycle is that progesterone serum level is quite good, and we don't have necessary to measure this serum progesterone level. But in this novel approach, when you give HCG trigger, for example, at follicle 14 or 15 millimeters, for perhaps it's rational that we must to measure progesterone level or no? Yeah. Your opinion and your clinical approach in these cases.
A very, very good question, because obviously we have seen that when doing a modified natural cycle, by using ACG for trigger and luteal phase support, we cannot see differences because the levels of progesterone are very high, but our criteria was to wait a minimum of 16 millimeters. Okay, so we don't know if the follicle was smaller, the capability of progesterone production would be the same. In fact, in pure natural cycles, it is seen that the amount of progesterone that the corpus luteum can produce depends on the estradiol that we saw in the follicular phase. So obviously this is directly correlated. And this is important for a pure natural cycle. If you are not going to give a luteal phase support, you need to trust on your follicle and to have a very good follicle. But obviously the ovulation will happen spontaneously. But once you are introducing luteal phase support, probably this is not so important, okay? But this answer cannot be given yet, because we don't know if with the smaller follicles, the serum progesterone levels reached in the luteal phase are enough to cover the luteal phase, and you can skip measuring serum progesterone levels. That's a very good point. Thank you.
So the question is whether this follicle of 13, 14 millimeters produces enough relaxin to avoid the complications that we know during pregnancy. So let us stress on the fact that when the study was performed, the retrospective study that you gently showed, the follicle between 13 and 16, and then the normal follicular diameter, and then the larger diameters. The smallest cohorts, of course, came from the 13 to 16 millimeters. So to be confirmed whether this is really okay to do in daily practice.
Thank you. Thank you so much. And the next question, please.
Thank you very much for great presentation. And I have two questions. Is it necessary to measure estradiol level with progesterone before cryo-embryo transfer? And do you monitor progesterone level after rescue adding progesterone in case of low level?
We systematically monitor estradiol and progesterone before starting the luteal phase, particularly in artificial cycles and also in natural cycles, okay? But what we have seen is that regarding estradiol, once you have an adequate endometrial thickness, this means that the patient is being exposed to adequate levels of estradiol because she has developed a good endometrium, okay? So we haven't seen a correlation of the levels of follicular estradiol or proliferative estradiol and the outcomes. But we give a lot of importance to the progesterone in the proliferative phase, okay? So if it is starting to increase, we have to decide if scheduling the embryo transfer immediately just to avoid an advancement of the window of implantation. So we try to schedule the embryo transfer if progesterone levels are below 1 nanograms per ml, because we have seen an impact. And the other question was, if we recheck progesterone levels after the rescue. We did that at the beginning, because when we started trying to investigate if the subcutaneous injection worked, we gave the patients the injection and we measured the progesterone levels 1 day after. In 100% of the patients, they had higher levels. And we decided to stop measuring this because it was not practical. Many patients come from abroad and you cannot keep them in the clinic just to recheck once we demonstrated that it increases, and most importantly, it is effective at the end, because when we saw that the results were absolutely comparable, you don't need to remeasure this, mainly taking into consideration this variation of progesterone throughout the day. So if you are giving subcutaneous progesterone, you have to take this into consideration when measuring serum progesterone. So it has some difficulties. But at the end, your objective is not to obtain high levels. If you measure progesterone 1 hour after the injection, they will be very high and you will feel like safe. But the important thing is to have at the end the same results as if the patient had a good progesterone level from the beginning. So the clinical outcome is your final goal, not the serum progesterone level at a certain point of the day.
Sure. Christophe, can you say? But estrogen measurement was the first part of the question.
Well, first of all, I fully agree what this professional, Elena Labarta, has told, of course, so nothing to add. But we did a study in our unit showing that the E2 level on the day of planning will not play a role. So whether you are in the lower percentile or the higher percentile with your E2 level, this will not have an impact. But
okay, thank you.
First of all, thank you for both of speakers for great talks. And I have two questions. The first one I would like to address to Elena Labarta. So do you think that maybe some conditions, some pro-inflammatory conditions like endometriosis, adenomyosis, might need a higher cutoff level of progesterone? So do you support Peter Humayden's study or not?
I love that question because we were commenting on this before. I mean, honestly, I think that we cannot answer this right now because it makes no sense. I mean, the problem with endometriosis or adenomyosis is that there is a well-described progesterone resistance. Progesterone resistance means that the progesterone receptor is not working adequately, okay, the signaling or the function. And no one has demonstrated that increasing serum progesterone levels is going to improve this situation, to generate more receptors or make them more active. So I think this is a bad interpretation of results because we cannot say nowadays that by increasing serum progesterone levels, you are compensating the problem or overcoming the problem of a progesterone resistance because the problem is on the target, okay, on the endometrium, and is how the receptor is working there. So I cannot say yes or not. I say that we need studies to address this.
So I have a desire to ask you one more question. Do you use in your daily practice these tests for progesterone resistancy, like Bruce Leslie published about BCL factor detecting, like...
About, sorry?
Bruce Leslie from US, he published studies about these tests for progesterone resistancy for detecting in the endometrium by immunohistochemical method the protein of lymphoma 6 BCL factor, that like a molecule that can like help us to understand whether this progesterone resistancy exists or not. And he gave a comment that according to his data using GnRH agonist can improve this progesterone resistancy.
Well, first we have to validate this test to say, okay, if this is the diagnosis, how we can treat this patient, okay? But this is more important even for treating patients with endometriosis because progesterone resistance is even more important in the ectopic endometrium than in the eutopic endometrium, and this is why many progesterone treatments do not work adequately in endometriotic patients. So I think that it's something starting to be analyzed. It would be wonderful to have this tool, but then once you have this diagnosis, to know how to treat this, because I cannot answer this now. We are doing research on that.
Great. Have a possibility to ask one more question? Okay. So very short question about weight loss in obesity before IVF, except the exercise and nice diet. Do you use in your daily practice medications like GLP-1 and glucagon-1 receptor agonists?
Until today, we have not been using GLP-1 agonists for two reasons. First of all, what we want to achieve is sustainability and long-term health and, let's say, preventive medicine, because I think we also have a role in terms of preventive medicine and not only curation. But there is a problem, of course, because we are going to start a study with GLP-1 agonists, because this is probably very effective. The only disadvantage is that when you stop your GLP-1 agonist, you know that you need to wait 8 weeks prior to the start of your treatment, and you know what happens? They again gain a lot of weight during that period. So in terms of your sustainability and goals, it's a delicate exercise, but we will catch that train of GLP-1 agonists soon, I think, yes.
Thank you very much.
I think that with Mounjaro, you tell, yeah, it's only 1 month needed. With Ozempic, you need to wait 2 months. With Mounjaro, you can, well, our endocrinologist is because he knows a lot about this, and this is the advantage that the period. Yeah.
Yes, that's very delicate situation. May I ask you? I saw this wonderful approach to do a separate workout and separate even department to treat morbid obesity prior to IVF or prior to pregnancy. But may I ask you? Do you have data? How many? What percentage of patients who refuse to do that kind of treatment, and what are you doing with that kind of patients who said, no, doctor, I don't want to do it, just go straight to the IVF or to the pregnancy? What are you doing in that case?
Well, we work with green light, orange light, and red light. So if the patient has a BMI less than 30, then it is up to her if she wants or not. So we can immediately start with IVF. If she has a BMI between 30 and 35, it's orange light. So she needs to present herself at least 1 time to the Fermet clinic, fertility metabolism clinic. And then if there is 35 of BMI or more, she cannot start ovarian stimulation, and she will stay to the Fermet clinic as long as she keeps that weight. Of course, because we are in France, you know, in France there is a whole grossophobia story, and with discrimination and so on. So we need to be very cautious and careful. This is why we rather reflect to the obstetric or the possible obstetric complications rather than the evidence that is not very hard with regard to oocyte quality and so forth. So we say, sorry, but we are not going to create obstetric complications for you with your BMI of 35.
35, so your threshold.
Can you find patients with a BMI of 36 in our unit? The answer is yes. So we have an individual discussion and case discussion if the BMI is between 35 and 40, and patients have undergone a lot of efforts to try to decrease their weight. Well, then eventually we will probably start them.
So, Dr. Labarta, what's your red and orange lines for that kind of patients?
Well, the recommendation is similar. Obviously, we cannot start any ovarian stimulation treatment in patients over 40 because of the anesthetic risk mainly.
Sure.
Okay, and we always send them to the endocrinologist in order to help them to lose weight. So we are aware of this. Okay, it is true that nowadays they are more prone to receive all these type of medications injected because I was telling Christophe before, okay, to Diego, that as it is like a rapid solution, many patients prefer this. It is a pity because the ideal situation would be, as Christophe says, okay, just a way of living and culturally, I mean, it should be like that. But many patients do not have time to lose weight and to be pregnant later. So, well, things are changing a lot, and many of them are more prone to receive this type of medication to lose weight much faster.
Yeah, well, this is for Christophe. You know what, it's like you talk like truly, you know what, about nutrition. It's like we say in the animals the same thing, you know what, you are what you eat. That's it, okay? And affect every cell in the body. Now, one of the things that is affecting, aside from the metabolism, is the pH and osmolarity in different environments. And And that's a question for you. Is anyone measure what is the pH and osmolarity at the intrauterine level, or what is the pH in blood for patients with different levels of nutrition, high level of protein and a lot of fat or not? Because that's the environment where the embryos are going to be.
I'm not aware of any data showing differences in pH at that level. I cannot answer your question, Diego.
Thank you.
You are aware?
So firstly, thank you very much for your excellent presentations. And one more question, please. What is your opinion about the embryo transfer in natural cycle in women with very, very early ovulation? For example, 7th day of menstrual cycle, 8th day of menstrual cycle. Can it be effective, or we need to prefer the artificial cycle in this case to achieve the results of pregnancy?
I think it depends on the endometrial thickness and aspect. Okay, the problem is when a patient, usually you see this in advanced maternal age patients, okay, that she's almost ovulating and she's still bleeding. She does not have time to get the endometrium ready, okay, because they have to clean and start to increase the endometrial thickness. But you have to trust absolutely on your eyes and how you see the aspect of the endometrium, because many patients have a beautiful endometrial thickness and aspect on day 7. So I don't think that this is a problem.
Thank you so much. And I think we are coming to the end of this section, so we need to give our speakers possibility not to miss their trains. So, and thank you so much. It was a wonderful section. Thank you for your experience sharing it with us. We have the next lunch break.
У нас сейчас кофе-брейк. У нас по расписанию мы должны были начать в половину. Давайте сейчас у нас 18 минут. Давайте 15:40 встречаемся здесь. Хватит на кофе, я думаю. Супер, супер. Спасибо. До встречи. Нас ждет очень интересная заключительная сессия.
part of the
Okay, I see. Okay, okay, see, I see. Hello? Can you hear me? That's perfect. That's perfect. Now is even better. So thank you so much. I would like to thank Sona-Pharm and the organizers and all of you to be here today for this intriguing meeting, nice topics, intriguing topics, challenging, with a very good, incredible faculty. And so you know you are very active in this, in questions and discussions. So I have a topic which is the role of adenomyosis in human reproduction and in particular in implantation. I have to confess that this is not my typical research topic, so I had to study, but this is something that we have to manage in our clinical practice. This is something every one of us had this question in his mind. What I have to do in this patient with this difficult uterus? How can I manage this condition? So, okay. So I have three major questions to share with you. The first is, why should we imagine that adenomyosis can have an impact on embryo implantation and pregnancy? So which is the rationale? The second is, what is the right way to diagnose the disease? Did we find an agreement? Because until a few years ago, it was quite subjective, the diagnosis of adenomyosis. And the third question, which is strictly related to the first two, is should we treat and how in terms of spontaneous conception, increasing probabilities, and what is even more important in our clinical practice, in the IVF context. So this is the definition of adenomyosis that we have in our mind. The pathology is characterized by infiltration of myometrium by endometrial tissue, of the myometrium by endometrial tissue composed of glands and stroma. So if you think about embryo implantation, the first idea I have in my mind is the quality of the soil. So if you have a look to what happens in nature, we have organic layer, topsoil. So if seeds have to implant and roots have to grow, the equilibrium among different layers of the soil is very important. And so I like to think that the endometrium is the same. So when we have adenomyosis, we have rounded and irregular foci of endometrial stroma, glands, in the myometrium, usually surrounded by bundles of hypertrophic myometrial smooth muscle. So in brief, we have mud covering the soil. So it's very difficult imagining that a seed can implant and roots can grow in a disaster like the total disruption of the tissue. So there is all the imagination is quite feasible, it's quite easy to imagine that implantation can be affected. So the question is, this is the theory, but what does really happen in the clinical practice? So first of all, adenomyosis is so heterogeneous. We can have so many, we can say direct and indirect evidence during our scanning. So we run the risk of something really subjective. Is the wall, anterior wall, symmetric, asymmetric? The cysts inside the myometrium, the vascularity. So everything sometimes suggests that adenomyosis is there. But it was very difficult in the last years to find a sort of convention agreement for defining the different kinds of adenomyosis. But if we don't understand it, it is very difficult to perform trials because the study populations will be very heterogeneous. So basically, what we have to keep in mind is that at the moment, the dominant idea is that the endometrial tissue can move directly from the cavity inside and can overcome the layer, the internal layer, and reach the myometrium. In this case, the junction, we call it inner adenomyosis. And in this case, the junction between the endometrium and myometrium is involved by the pathology. In some other cases, we can see something only in the middle, in the deep layers of a myometrium. We don't see adenomyosis on the cavity side, and we don't see adenomyosis at the external side of the organ. The third possibility is that adenomyosis is only present in external, on the serosa, outside the surface, on the surface of the uterus. And infiltration is from external side to internal side. We can understand that the position of adenomyosis can have a different impact on the capability of the uterus to sustain implantation and pregnancy. So why this tissue should have the capability of infiltrating? We don't know exactly. We don't know if the pathogenesis of these three kinds of adenomyosis is the same. What we know at the moment is that probably some particular mutations or biological characteristics of the endometrial cells are the key point for giving to these cells an increased capability of infiltration. So probably the most relevant mutation has been identified up to now is related to KRAS gene, because KRAS is very important in regulating AKT and transduction signaling for surviving of the cells. So if the clearance of KRAS is altered, the capability of cells to go toward clearance is reduced, and so the survival of these cells is higher. So probably mutations like this are very important for making the difference between an endometrium that will go in apoptosis and endometrium that will be more viable, more aggressive, with the capability of infiltration from outside, like the endometriosis, from retrograde menstruation, and this can justify the external adenomyosis, or from inside, that can justify the inner adenomyosis involving the junction, which is, in my opinion, obviously the most important. And another concept that we have to keep in mind, because it is very important for our clinical practice, is that we don't know exactly the mechanism, but the expression of isoform of progesterone receptors is decreased in adenomyosis, meaning that this uterus can be more resistant to the activity of progesterone. So this is associated also with inflammatory process, impairment of immune response, and cytokine interleukins. So obviously the tissues we can say is totally altered, also probably in terms of immune and inflammatory regulation. And what is important is also associated with the local production of estrogens. The aromatase is more active. So the progesterone is less effective because the expression of receptors is lower, and the local production of estradiol is higher. I'm focusing on this because this is the rationale for understanding our approach in IVF when we have this kind of uterus. So having this concept in mind, there are so many studies, but few of them have been made improperly. So studies in time lapse related to capability of understanding contractility of the uterus in different phases of the menstrual cycle. And there is evidence that patients with adenomyosis have this kind of alteration that are more pronounced during the luteal phase, where it has been observed increased amplitude, decreased velocity, and decreased coordination. So we have local hyperproduction of estrogens, reduced sensitivity to progesterone, inflammation, and alteration, very important in the contractility. So we can understand how the same disease, according to severity and according to position and according to pathogenesis, can affect the reproductive process in a different way. So when we have to design a trial, what we have to decide is which kind of endpoint we would like to use for understanding the impact of a therapy or the impact of a given disease on, in our clinical practice. But you can imagine how many confounders are there, because we have different kinds, different diagnosis systems, different positions, different severity, different pathogenesis probably. So if the endpoint is miscarriage rate, probably one kind of adenomyosis can have an impact. If the endpoint is implantation rate, probably some other kinds of adenomyosis can have an impact. So second point, given that the situation is so complicated, did we find an agreement for understanding which is the right way to diagnose adenomyosis? Because I'm convinced that if I ask all of you, what do you think? Somebody will tell me MRI is the only way for objective evaluation. Some other people from ultrasonographic kingdom will say that only Musa criteria at the moment are trustworthy. And so if I talk with my friends that are involved in hysteroscopy, they say only what if I see, I can treat, and this is the only relevant adenomyosis. So it's very difficult to find a compromise. So because what we understood is that once we had more modern strategies with MRI and basically scanning, USG, we understood that the pathology, the old paradigm has been overcome. And what we know now is that the pathology is very common because the diagnosis became non-invasive, and the percentage of patients, in infertile patients in particular, having the disease seems to be very high. I say seems because once you have this kind of possibilities for diagnosis, we also run the risk of overestimating the real incidence. Because you can have signs, indirect signs, that probably are suggestive of, but we cannot prove that adenomyosis or relevant adenomyosis is there. So scanning USG became dominant in the last years, and I will not spend so much time in this, but we all know that the scientific community of the USG kingdom found recently disagreement, which is called the Musa criteria. So I don't want to go, we don't have time to go deep inside, but the system identifies direct features and indirect features. And so the presence of one direct feature and more indirect or two direct features is suggestive of adenomyosis, or gives us the possibility of diagnose the pathology. So it is a system based on the association of direct and indirect signs. So this system found an agreement in the scientific community. I think it's the most adopted system, classification system at the moment. But on the other side, as I mentioned, there are other countries philosophies, and so there are at least 4 study proposal. There are a group of researchers that think that MRI is the only way to make the diagnosis subjective. So what we can say that at the moment, having as a gold standard histology, the diagnostic accuracy, meaning a positive likelihood ratio, negative likelihood ratio, are comparable between MRI and scanning. So the match is on cost-effective sometimes approach, because obviously if the diseases is so frequent, so you can imagine what does it mean sending all the patient to do MRI for this kind of a condition. So also the waiting list for this kind of exam for other disease can be affected, but it's a very personal and I think subjective approach. And so what about the hysteroscopy? One could say hysteroscopy doesn't give so much information, but this is a topic that has been proposed for many, many years. There is something, in Naples we have a very well recognized unit of hysteroscopy by Professor Di Spiezio. So we have the possibility of performing an incredible number of see and treat procedures per day. And we have to recognize that you can directly see is important. Basically, for the possibility you have to directly treat. And so, for instance, with the direct visualization, you can see irregular endometrium with tiny openings. It's very typical. It's a direct sign, strongly suggestive of adenomyosis. Or you can have again, different kind of openings, but what I find very intriguing, which is quite common, is the presence of hemorrhagic cyst lesions that are typical with a dark blue and chocolate brown appearance. And so we can also have indirect signs. So if we put attention in this, we can easily understand that the limit of the hysteroscopy is that you can see only the surface. But let's imagine what it is if we want to understand more about the junction and about what we can see by hysteroscopy at the same time. I like to imagine the one-step uterine diagnosis, because you can have, we do it every day. You have at the same time hysteroscopy and scanning. And so you can have a precise mapping of the disease and you can treat what you see at the moment. So I think this is very promising. So I don't think that at the moment we have a gold standard for diagnosis, but MUSA criteria are growing. The agreement among specialists is increasing, and now we have for the first time the possibility of performing trials that have been more controlled, that are more controlled in terms of endpoints and inclusion and exclusion selection criteria over the patients. So a few minutes, but I think this is the most important topic. Should we treat? So let's have a look to what happened in the last years. Up to 2-3 years ago, this meta-analysis is 3 years ago, taking into account trials that had been published in the previous years. So everyone suggested that adenomyosis has an impact on the outcome of IVF. So if you have a C2 live birth rate, the meta-analysis suggests that is significantly reduced. Miscarriage rate is significantly increased. The scenario changed in the last years because other kind of studies had been published that failed to find a so relevant association. But why? Because these new trials were performed using MUSA criteria. It included the patients with only indirect and small signs of the disease. So this is just to give you an idea that when we read the literature, we have to open mind and we have to understand which kind of patient had been included. For instance, if we consider this experience by outside the nation programs that has been published 1 year ago, you can see that the miscarriage rate is dramatically increased in patients with adenomyosis in outside the nation program. We're talking about recipients. So if adenomyosis is there, you have dramatic increase in the risk of abortion. But which kind of adenomyosis? Because the previous study was based on Musa criteria, direct one sign or indirect signs of adenomyosis. In this experience, just 2 kinds of adenomyosis had an impact on the outcome of the IVF in terms of miscarriage rate. Severe, meaning involving the vast majority of the organ, and involving the junctional zone. So the real difference in terms of contractility and capability of implantation before and risk of abortion later on is the unstable condition of the junction when it is infiltrated by adenomyosis. So let's go on. This is perfectly consistent with a study that in my university was made together with the group of Katerina Xakousas. This is in spontaneous conceptions. And have a look only on the left side. If you have patients with repeated pregnancy loss, patients with adenomyosis had a higher number of abortions in the history and younger age at the moment of the first abortion. So when we think about repeated pregnancy loss, we have to think that adenomyosis can be a possible relevant cause, one of the causes of repeated pregnancy loss. So this is perfectly consistent with the data I presented from meta-analysis. So what's going on? Different phenotypes, different reproductive outcomes, what I said before. And now we come to this year, 2025, and again, in this case, it has been diagnosed with MRI, and again, the concept is here. So the presence of internal and diffuse adenomyosis. So the only, in terms of evidence, the only thing that we can say now is that the junction has to be involved or the process has to be diffuse, has to be, the severity has to be relevant. And in this trial, even an impact on live birth rate has been reported. So, given that there is sufficient evidence to think that at least some kinds of adenomyosis have an impact on the outcome of IVF, what we have to do? We have to propose cycle segmentation, frozen embryo transfer, having the highest number of euploid blastocysts, because if the probability of any single implantation is reduced, having more oocyte and euploid blastocysts give us the possibility of different attempts, increasing the probability that at least one will implant. But independently of this, the frozen embryo transfer, meaning not pushing too much the endometrium at the moment of the implantation with exogenous estradiol after stimulation, can be an option. The second, should we treat the patient in case of frozen embryo transfer, should we treat the patient with the generate agonist or oral antagonist or with other kind, dienogest or other kinds of procedures? The third, is there a place for a surgery? And the fourth, are we studying other options? So I just have one slide for a question of you. Frozen embryo transfer. It's clear, frozen embryo transfer, if we have this kind of a treatment in this trial that has been published 3 years ago, the frozen embryo transfer with the pre-treatment with agonist has been compared with different kinds of approach in fresh embryo transfer. In all cases, frozen embryo transfer gave better results. So cycle segmentation, I think this has been also confirmed by this meta-analysis and by this other trial, having as endpoint cumulative live birth rate and cumulative ongoing pregnancy rate, and in both cases, cycle segmentation had better, significantly higher results. Why? Because what I told you at the beginning of the trial, of the talk, we have a condition where there is a resistance to progesterone, but what is even more important, there is high local production of estrogens that is related to inflammation. So if we transfer an embryo after stimulation when estradiol levels reached 1,000, 2,000 picogram per ml. So the exogenous production of estradiol, the internal production of estrogens by the lesions, probably is very relevant in terms of implantation and regulation of implantation window. So cycle segmentation is a way for having euploid embryos, a given number, the higher number possible of euploid embryos, and then treat the endometrium and the uterus in terms of reducing the inflammatory effect of adenomyosis, in terms of managing in a personalized way the contractility of the uterus. So first take-home message. The first is if you have severe adenomyosis, inner adenomyosis involving the junction, we need cycle segmentation. Second questions, what about GnRH agonist pretreatment? I think it works, but I was very surprised in understanding that we don't have so much trials on this. This is clinical practice. Why? Because all the studies that used agonists were studies where the use of an agonist was associated with fresh embryo transfer and compared with the frozen embryo transfer. So cycle segmentation, pretreatment with agonist, and then transfer has been studied in a very restricted number of trials. Obviously, the trend is in favor. We don't have so much relevant difference by statistical point of view, because you can see that a meta-analysis with heterogeneous studies not reaching 500 observations per group is not sufficient to conclude the match. But the trend is in favor of treatment with agonist in cycle segmentation before transfer. So surgery, I think that when you can see, I told you before, this is, we don't have time, this is an experience we had with Attilio Di Spiezzo recently in our unit. So we had the cases of a clear, evident adenomyosis involving the cavity, meaning chocolate cyst, dark blue cyst involving the cavity. And so we had 4 patients, obviously, it is not statistics, with a repeated implantation failure that had been treated for adenomyosis with agonist, cycle segmentation, euploid blastocyst. And 3 of them following the hysteroscopic resection of the lesions that we could see had the pregnancy, 1 aborted, but obviously it was, in my opinion, a good result. And I think that integration between pharmaceutical approach and when required surgery can be very important. Just 2 considerations about other options. So this is what we know about the progesterone resistance. We know that there is progesterone resistance. And so this is the famous trial demonstrating that in endometriosis, more progesterone is required, meaning that if the patients have levels of progesterone at the moment of the transfer, the embryo transfer, above 37 nanogram per ml, the probability of implantation and ongoing pregnancy rate is significantly higher. But we only have this information for endometriosis. I don't know at the moment if cut and paste we can apply to isolated adenomyosis or different, but I'm confident that this is the case. And so this is the experience by Mauro Cozzolino that had 3-4 pregnancies in patients where the use of agonist before embryo transfer was not able to dramatically reduce estradiol because probably of the local production of estradiol by lesions, and he treated the patients with a combination of agonist and letrozole for pushing the estradiol at the lowest levels and increasing the probability. So we need to test these options. So, but what I think that we have to consider, matching together all the things I said, is first trying to have, if it's an IVF, a higher number of euploid blastocysts, because you need more attempts. So if it is a slight disease, few symptoms, probably you can try standard IVF in case of, depending on ovarian reserve, the age of the patient. And after 2 attempts, probably you can do to freeze, PGTA, and euploid program segmentation. But if you have evidence of a severe disease, diffuse, and what is very important, the involvement of the junction, the best thing to do is cycle segmentation. Go straight to egg collection, because I don't think that pre-treatment is required, because we don't have evidence that adenomyosis has an impact on oocyte quality. So don't waste time. Try to have the maximum number of oocyte and euploid blastocysts, and then cycle segmentation. So this is what, I don't want to read the conclusion, this is what I tried to step by step. I like to conclude with 2 slides. One is the consensus of Lugano about adenomyosis. Very nice attempt to find a solution, but at the end, the conclusion of the consensus is that we have heterogeneity of kinds. We don't know which kind has an impact. A most suitable therapeutic approach to bioisoinertive needs to be explored. Pathogenesis of adenomyosis should be further clarified. So we don't know so much things. The only thing that we know is that what has been proposed by so relevant study, Baris is here, and so this is fantastic that now we know the relevance of having more euploid blastocysts. But at the same time, the embryo is probably the main determinant of implantation. But unfortunately, if we consider all the pathologies together and the patients having up to 5 euploid blastocysts, they are a very small percentage. So we have to take into account of all these diseases. And so that's the reason why Diego knows that I love Diego, because I've been in Naples. I was born in Naples, and you can see Diego Maradona. Why? Because in my opinion, Diego Maradona is the perfect euploid blastocyst. And so if you have a perfect euploid blastocyst in a perfect uterus, the result is this. You can see. This is the first penalty, first score. But let me tell you another thing. If you have a situation like this is considered the best scoring of Diego, because it was impossible, because it was in the penalty area, but the wall is just 2 meters, and the angle was considered impossible. But obviously, he scored. So this is, according to somebody, this goal is not possible by physics point of view. But this is what happens when you euploid the blastocyst implant in junctional zone. So why? We can have 5 euploid blastocysts, okay? And so one of them can be Diego, but it's not. And this is what we can reach with our treatments. So something that is intermediate. A scoring that is everyone can do with a little of effort. So thank you so much, and I apologize if I have taken a little bit more time.
Thank you, Carlo. It's fantastic, and I love the Maradona. It's impossible for an Italian to score that, but not for an Argentinian.
Next time I will show you some. I will show you some Baggio scoring.
Not for an
Probably even better.
No. Actually, the Argentinians score those goals. You know, now we have Messi doing the same thing. So that was a great lecture, because actually most of the times when you see comorbidities like this that are affecting fertility, you need to have a very clear path to treat it, or go like in many cases. Yesterday I was talking with Luke Rombouts about endometriosis, and I said, what do you do? I said, I go IVF, unless you know what that's like. I go IVF and there's no difference, so it's good. So it's very important to understand. And he said that unless you have endometriosis with adenomyosis, I go straight to IVF. So it's very important to consider this. So now we're talking about something that's really important. We have a good friend also, a great doctor, also a great human being like Carlo. And he's going to talk about something that has been discussed over and over and over again. And I think that at some point of time needs to be a discussion even further to see how can we objectively measure the receptivity, the potential of the uterine cavity to receive an embryo, independently of the thickness of the endometrium, but have something that measure objectively, so you can do it before transfer, and then you're going to be able to say, okay, you know what, it looks good, but still not good. But we're lucky here because we have a chairperson and full professor of the Department of Obstetrics and Gynecology of the Koç University in Turkey, which also is working, you know what, in a unit, one of the most prolific units producing papers in Dubai and Abu Dhabi. So let me introduce Professor Baris Ata, that is going to talk about how important it is, how important it is, the endometrium, the thickness and everything.
Yeah, maybe we should take it.
You talk. I don't need to talk, okay, anymore.
Anyways, thanks for the kind and long introduction. Okay. So anyways, today is about why embryos don't implant. And actually, I have two talks. If you want, I can switch. This is more about thickness. I have another talk about how to assess it, but it's not the talk, but the technology is inconclusive at the moment. So I'd like to stick to this. But yeah, when we have time for questions, I'm happy to go into other markers, other technologies. And how do I move the slides? Is there a pointer or something? So Carlo, you liked it?
No. No, because sometimes it can happen, but no.
There's no clicker. Where is it?
Is it that one?
That one. Yeah. Good eyes.
All right. Maybe I can even borrow your microphone. Anyways, I don't know. Down. All right, down. Fine. Okay, let's try. So you can read this. Can you measure endometrial function with thickness, or endometrial thickness is a reason, or thin endometrium is a reason for implantation failure? So the background is I've been doing IVF I have been doing it for more than 20 years now. Time flies really. And when I was a trainee, this was still an issue. Right? So what do you do when the endometrium is not 7 millimeters, when it's not 8 millimeters? I never understood it at the time. I don't understand it today. Anyways, and the practice was you would try a lot of other stuff, give more estrogen, give whatever, aspirin, etc., and then cancel the transfer. I've seen people who have been dragging for months and months, cycle after cycle, knowing the endometrium is not good, endometrium is not good. Let's see if this is justified, okay? So these are the disclosures, and none is relevant. If you are supposed to, or if you wish to, or if I wish to, modify the management of the transfer cycle because of endometrial thickness, I should be able to answer 4 questions if it's a rational thing to do. 1, is the endometrium thin? How do I define thin? Okay, and then if I decide that it is thin, the second question would be, is thin endometrium really a bad thing? So is it associated, really causally associated with lower chance of live birth? If that is the yes, then the third question would be, is there anything I can do about it? I mean, can you thicken a thin endometrium? Right? Is there a proven way? Okay, so it's 6 millimeters. I'll do this, and next cycle it will be 8. Right? Does this exist? And more importantly, even if I was able to increase the thickness, does it increase the chance of live birth? Right? So if the answer to all these questions invariably, the answers are yes, then it may be the reason for not implanting or not reaching live birth, or you can cancel, you can modify. But if only one answer is no, then you shouldn't mind it. Doesn't mean don't research on it, but I mean don't drag people for months and months. So let's see what are the answers as far as I understand. So thin endometrium, if we did a poll in a preferably like multinational auditorium, without, you could come up with different numbers. So if you read the literature in detail, it is, to me, astonishing. Like, thin endometrium has been defined as less than 6, less than 7, less than 8, less than 9, less than 10, less than 14. Right? So that studies are published. Right? So 13 is thin, 15 is okay, 8 is thin, 10 is okay, etc. So there's no uniform, threshold that determines thin or thick endometrium. Now, but yeah, we have to admit the fact, usually the number is around something like numbers like 7 millimeters. Okay? That's where the clinical questions comes from, or the papers. I was curious to find how did we come up with this 7 millimeters? What was the original paper? What was the original finding? Why wasn't it 6? Why wasn't it 5? Why wasn't it 8? And this is a real paper too, but from a different field. That's what I came across during my search. This is a paper from cognitive psychology, okay? And it is, like older than I am. The author was a Harvard faculty member, right? And as you can see, maybe we have something about 7, 7 wonders, whatever, 7 sins, etc., etc. Or, maybe there is really something about 7 millimeters with endometrium, but that doesn't sound that unreasonable once you go through the literature. So this is as far as I can find, like the first ever paper. There's another one also, same group, same year, that mentions, okay, so nobody with an endometrium 6 millimeters or less got pregnant. Right? So this is 35 years ago. Even vaginal ultrasound was not the standard. Okay? And that group, one of the pioneers in Canada, in IVF, Robert Casper, whom I respect a lot, right? But 35 years ago, they were doing like 100, 150 cycles a year, okay? And with the technology of the time, the field was new. Look at the name of the journal. It exists under a different name today. It's the Journal of Assisted Reproduction and Genetics today, okay? And as the field was new, you could publish a paper with retrospective analysis of 100 cycles, etc. We were doing a lot of, actually not me, I wasn't even in medical school, but anyways, so there were a lot of fishing experiments, not in the bad sense, so the things were new, hypothesis generating studies. Let's compare who got pregnant, who didn't get pregnant, so what are the differences, could it be, could it be that, we need to investigate further. And when you read the full paper even, you can't tell how many patients there were with an endometrium of 6 or less, so I assume it should be more than 1, as it says no patients, but could be even 1 or 2, okay? Shortly after, we knew that it's not a biological limit, okay? So there are papers showing someone getting a live birth with 3 millimeters, 4 millimeters. It's not a biological cutoff, right? So it could have been a whatever, chance finding. Now, if we still assume thin endometrium is bad, I mean, millimeters are huge for the embryo. It's not lack of space. There must be another reason why it should be malfunctioning, right? So one theory, 19 years later, is this is a Japanese study, nicely done. Patients had a stimulated cycle. Some of them had a thin endometrium, which was defined by less than 8 versus more than 8 millimeters. And later they got endometrial biopsies from the patients and looked at several things. One, the area of the blood vessels, the surface area of the blood vessels. So thicker endometrium was better vascularized. VEGF expression, the thicker endometrium was expressing more VEGF, And the idea was, okay, so then, listen, the thin endometrium is thin because it is not receiving enough blood supply, it's not receiving enough oxygen, so it cannot nurture the embryos. And even before this paper, patients were being put on aspirin, Viagra, okay, a lot of other stuff to improve blood flow, as if it was the problem. Then, 2 years later, Robert Casper again, he comes up with a different theory, which is very reasonable. Why, so, why would a thin endometrium be a bad thing? It is thin. When it's thin, when I put the embryos on it, the embryos are closer to the basal layer, because I would be putting the embryo on the lumen. So when they are closer to the basal layer, which has the spiral arteries thicker, even more blood flow, more oxygen, reactive oxygen species. So maybe it's bad for the embryo, because what we've learned in those 19 years, the embryos didn't like oxygen that much. We know from the culture systems, we know from the incubators over time, in the intra-abdominal environment, the oxygen tension is lower than the ambient condition. And once we had these triple jacket incubators with lower oxygen tension, you have better embryo development. Which one is the case? I don't know. Maybe neither, because maybe a thin endometrium is not necessarily a bad thing. Okay? So the point is, we don't even have a unified theory, a biological rationale, why a thin endometrium would be a bad thing. Okay? But still, look at the number of papers and multiple meta-analysis. Why? It's simple. Why do the journals keep publishing, same thing again and again and again and again? It is, first of all, convenient. We have to do ultrasound to monitor follicular growth anyways, and ultrasound is wonderful to diagnose or exclude obvious problems with the uterus. Ultrasound is wonderful to diagnose adenomyosis. Ultrasound is good at diagnosing polyps, fibroids, etc. Okay? And you happen to see endometrial thickness, right? Then, okay, so why don't I do the study? Again, you can even do it retrospectively, like the majority of these studies. And then here comes a paper, okay? And you even can meta-analyze it. Let's see what happens with these a lot of papers. We reviewed them, one by one by one by one. You could be surprised, not only the threshold to define endometrial thickness varied from 6 millimeters to 14, even the day of measurement is not standard. If you read the detail, you could see on the day of trigger, on the day of egg collection, on the day of transfer, etc. And in retrospective studies of frozen embryo transfers, particularly with the program cycle, if you pay attention, it's not necessarily the day of progesterone start. And it's not even always mentioned specifically in the papers, right? And then how do people calculate these values? Through several ways, some of which make sense, some of them not that much, and there are a lot of other methodological shortcomings. But the point is, sample size, one. Earlier studies, you could publish a paper with 100 patients with only 20 of them getting pregnant, a very low event rate. You could observe a lot of chance findings. Now we have registries, we have computers, everyone has access to statistical software. You see papers with 100,000. Right? You see Chinese papers with even higher numbers. And since statistical significance is related to the sample size, whatever you compare in larger samples, you'll likely find statistically significant differences, which doesn't necessarily mean they are clinically relevant. And regardless of how large retrospective studies, whether it's national or international registry, as long as it's retrospective, the data is produced is accumulated based on the practice pattern. If people have been canceling transfers because they think the endometrium is low, they don't appear in the registry, even if it's 1 million cycles, okay? So that whatever the study is should reflect what's happening in the nature. You need to understand what's happening in the natural course of events. So we plotted the prevalence of thin endometrium across the sample sizes of individual studies. We defined it with 7 millimeters. You see in some studies, it's less than 2% of the overall study population, or in some studies it's like 7%, and in the study at the top, which is one of our studies, it was 12%. In that study, we were transferring regardless of thickness, so I can tell you, if you transfer regardless of thickness, almost 1 out of 10 patients will have a thin endometrium. And in these studies, a lot of patients have been canceled. We don't know what would have happened if they received the embryo transfer. And probably everything has been tried to increase the thickness, and then when it doesn't happen, you eventually end up transferring, so they're not necessarily usual thin patients. And this is a paper we're just about publishing. Actually, I was just looking at the PDF proof now. It will appear in Human Reproduction. We presented it, I think, on Monday. So this is a multi-center study. There are 27 clinics, US, Spain, UAE. When you look at the prevalence of endometrial thickness, you see it's the lowest in North America. What we understand is our colleagues in the US, they are not transferring when it's thin. They try everything, so it's like almost 2%. In Spain, it's in between. As in our practice, we put the least emphasis, the yellow bars, so we had the highest prevalence of thin endometrium. And this is 30,000 cycles. That is to show how data is generated differently, right? So even if it's 1 million cycles, it only reflects what has been done in that practice. Now, another methodological problem, you can think that measuring endometrium is very straightforward, which it is, but consider it's like a teardrop. Where do you put the markers? Then it's 3-dimensional. Is it exactly perpendicular in every direction, right? And if that's a nice study, if 2 physicians in the same unit measure the endometrial thickness for the same patient, 10 minutes apart, blinded to each other's measurement, you see the variation in millimeters, okay? And if it's like 1 day apart or 2 days apart, it's even wider. It doesn't necessarily grow 6 millimeters in 2 days, okay? So I would say it's not necessarily a reproducible measurement, and it's not necessarily that precise to inform an important clinical decision like, okay, I transfer to this patient or not, as long as you exclude other stuff. Then, now you see, these studies, I said everyone has access to statistical software. So we did this analysis, we did regression, we did that, blah, blah, blah. There are important details missing in almost every paper. Right? 1, the association between 2 variables in the context, say, implantation, live birth, pregnancy, and endometrial thickness, it's not necessarily linear. It could be quadratic, it could be inverted U-shape, it could be U-shape, there could be no association. But the thing is, okay, to assume an association is causal, right? It reflects a causal relationship. If you see a gradient, you can also call it a dose-response relationship. So the thinner the worse, the thicker the better, like a linear relationship, okay? It would be most convincing. U-shape could be acceptable as well. Maybe the extremes are bad, but the point is, this is not necessarily reported in the papers. And then you read, okay, so we did the regression analysis, we added this, we added that, etc., blah, 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 blah. All of those associations require different regression models. And even if you choose the right model, depending on how you introduce the confounders, anyways, to keep less detailed, how well your model, your regression model, the formula, explains the distribution in your data is another story. You may get a number, but does your formula, does your solution explain 10% of the variation in the data? Does it explain 90% of the variation in the data? How well it fits to the data determines how confident you are about it. And there's a statistic for it. It's never reported in the papers. It's also, it's also the fault of the editors. They're not asking for it. So just don't assume, just reading there's a regression model, that means all the confounders are adjusted for, and whatever the result you're seeing is necessarily precise. So enough with criticism. I've been criticizing everything. Everything is wrong. Not everything is wrong. So how should be a proper study, or how do we make sense of what we read nowadays? So ideally, a study should be prospective. Like you should start, you have a protocol, you should keep transferring regardless of endometrial thickness, so you observe what happens in the natural course, okay? Obviously, you should rule out other problems with the uterus, and ideally, we should report live birth obstetric outcome. That is key. Do not modify management based on endometrial thickness, see what happens. Then analyze appropriately, as I just mentioned. And if you still find lower chance of live birth with a thin endometrium, you need to quantify it. How much lower is it? Is it like, say, 50% lower? Is it 5% lower? Is it relatively? Is it absolutely? So how do you inform yourself? How do you counsel your patient? So now, prospective studies are better, right? I don't think anybody would contest it. If you look at the published literature, when you pull the data from prospective studies, you can't find a threshold, or you can't say thin endometrium is a bad thing. It comes from the retrospective studies, okay? So if I would choose to rely on one, I would choose believing in the prospective ones. This is one of our studies. It is retrospective by design, but since I've been transferring regardless of endometrial thickness, as long as I rule out endometrial, like intracavitary pathology or premature progesterone exposure, if I did it prospectively, it would be the same. What we observe in fresh or frozen cycles, okay, there's no pattern, and I can't give you a threshold below which you have significantly decreased live birth rate, okay? So they're extreme patients, but it's just one, and I'll show you a larger data set, but if you pay attention, below the infamous 7 millimeters, overall live birth rates are pretty high, and which we also did replicate. This is again retrospective, but it was nice to see Human and I, we think similarly with this thing, and they were transferring regardless anyways. And in a natural cycle, pure natural cycle, even without the trigger, pure natural cycle frozen embryo transfer, you have no control over endometrial thickness. Whenever the patient ovulates, you schedule the transfer, right? You see euploid blastocyst almost 1,000. However you look at it, I can't tell if there's a certain association, or I can't pick a certain threshold, and below 7 millimeters, the live birth rate was 47%. And in our case, without the PGTA, it was almost 42% in a smaller cycle. And now, this is the new paper that's coming up, 30,000 euploid blastocyst transfers, all broken down North America, Spain, and UAE. The data is dominated by North Americans, so 78% of the data is programmed cycles, almost 19% is modified natural with the trigger, and 2.5% is pure natural, which is the one at the bottom right, okay? Here, you see a band. I'll show you that's the regression graph. red line is natural, endometrial thickness, chance of live birth. The blue and the yellowish are modified, natural, and programmed. So we know the prevalence of thin endometrium is different, not that we measure differently, but the Americans, they're trying to avoid transferring, even though we excluded obvious factors. We think these people may be slightly different for whatever reason, and what we can also see, you can modify your management, you can manipulate the programmed cycle, the artificial, the HRT cycle, and the modified natural cycle. You can extend estrogen exposure, you can try to delay the trigger by a day or two if you're not happy with endometrium, so you're sort of distorting the data. In the pure natural, in the red line, there's almost 800 transfers, single euploid. You see that one, that's what happens. That's the best model to understand biology to me. And when the patient ovulates, you schedule the transfer, regardless of endometrial thickness. There's a small slope, there's a small slope, but you don't see an obvious bend, okay, in the natural course of events. So that is what I think that is in reality. And obstetric outcome, on the right side, there are papers which suggest thin endometrium is bad on the left side. On the right side, there are papers which suggest it doesn't matter. So the point I'm trying to make is in the literature, you'll find every result you look for. It's always published somehow in retrospective. We need to make sense of it. The jury is still out on that. I don't think it's depending on the underlying reason. What we're referring today is it's not scarred endometrium, it's not infected endometrium, etc. It's just nice looking, good, without risk factor, thin endometrium. So, to me, the answer to all these questions, which we don't have this answer, but it will come soon. I'm aware of a study looking at this question, okay? I think it will be published. It's not one of our studies. I just happen to be involved with its assessment. But the answer to this study is also, this question is also likely a no in the context. So I think if you are certain that you ruled out obvious uterine pathology, if you're certain that the patient has not been exposed to progesterone by using the medication, erroneously or whatever, premature ovulation, etc., then rather than dragging her by cancellations, we can just move on. So, in conclusion, in the past, unlike the technologies, the molecular technologies we have today, endometrial ultrasound was one way of assessing it, and it's a marker of convenience, but it doesn't necessarily reflect function. And the endometrial thickness measurement, how simple it looks, it's not that accurate or reproducible to rely on it for clinical decision making, maybe except at the extremes. Retrospective data can be always distorted by the practice pattern. I am not aware of a proven effective method that increases the thickness of a thin endometrium. If anyone knows, I'll be happy to learn. But once you cancel a transfer, it makes sure that the patient is not getting pregnant, okay? So if you transfer, even if it's slightly lower, she still has a decent chance, okay? So that's my conclusion. We need to accept things as they are. Not everything, but I think endometrial thickness, and then move forward. I hope it wasn't too long.
No, that's perfect, perfect. You keep the microphone. You Carlo, can you sit there, please? I think that, you know what, I love that. No, Carlo, please. It's working. So, you know what, one of the things that I really love from your lecture and from all the things that we're looking at, and I think that the majority of the doctors that I see here are young doctors, okay? And one of the things that I see, I've been lucky enough to travel around the world and visit multiple clinics. And one of the things that I see every time that you practice is that the majority of the practices that are doing IVF are doing things based on dogmas. And these dogmas were established probably, we say, 35 years ago, 40 years ago. Some of the things, the other day we were with Human Fatemi, we were talking about who decided that the triggering diameter of the follicles needs to be 17 millimeters. Do you know who decided? Well, you know. Do you know?
No.
Do you know who decided that 17 millimeters is the... No? Okay. He said Human said, I was a student at Belgium, and I was one of the senior doctors right there that was trying to, said, what are you doing, says Human. Well, I'm trying to do a study, you know, to find that triggering time for the ovulation, whatever. And Human said, so what is going to be the measure? 17 millimeters. So it came from the idea at the head of someone that at some point of time decided to do it 17 millimeters. And now, Human is triggering in patients that are older at 11 millimeters, and he's getting better results than triggering in bigger follicles. So before asking questions to them, I encourage each and everyone in the audience, younger or older or whatever your age is, to challenge the dogmas. Because like he said, the paper was written by one of the most smartest doctors that I know, that is Bob Casper. That is one of the guys that discover everything. And how can it be that we still do not have a measurement, not only of the diameter, but the functionality of the endometrium, objective to really define if you need to put the embryo in or not? Makes sense what I'm saying?
Yes.
So challenge dogma. So questions for Carlo and for Baris. Yeah. Question here. I give you the microphone. You raise your hand. It was not for a question? No? No. Okay. Who has a question? Okay, you have a minute.
Diego, Carlo, Baris, thank you for coming to our big family today. What do you think? Can we find the light at the end of the tunnel with the endometrium, with PRP and exosomes? And if yes or no, how can we research it and figure out the correct answer?
I mean, thank you for the opportunity. Wonderful question. Long story short, even my friends sometimes, criticized us for these papers, and the other paper Carlo showed, the 98% cumulative live birth rate. So you're neglecting the endometrium. Right? So what do you mean? Does endometrium doesn't matter? That is not the case. Right? So the embryos, they don't implant on any surface. I mean, they need a receptive endometrium, which is regulated with the hormones, etc. So it matters. But looking at the data from consecutive euploid blastocyst transfers, so it seems the failure is mostly because of the embryo, right? So less often from the endometrium. Obviously, adhesions, polyps, etc. aside. So now, do we have a way of reliably measuring its function, right? I gave a talk for another company 2 days ago. It wasn't one of my best performances in my opinion, but because I don't like talks with negative messages. One, why don't you sit down, by the way, you're so kind, but it will take a while. So 15, 20 years ago, Carlos Simon had a great idea. What if the window of implantation is shifting? Right? So what if it varies between individuals, between cycles? So the transcriptomic analysis was a great idea. The only thing is the particular test doesn't seem to work after, we see it over the years. Over the years now, we understand it doesn't work. But maybe another combination can work, but it's not available at the moment. Then there was the microbiome. I started doing microbiome research, I don't know, maybe like 8 years ago. Then the way the data is analyzed, and after I understood it, I said, listen, I mean, this is in its infancy, and I didn't want to invest more time in it. you see everything is going upside down in microbiome. I mean, so if you read the papers, it says, what is that we are analyzing? We are analyzing 16S ribosomal RNA. We are not looking at the RNA. We are looking at the DNA sequence coding it. And if, just like the Jurassic Park, if a bacteria was in that location sometime, you'll always find that DNA, but RNA sequencing completely paints a completely different picture. So the DNA data suggested endometrium was supposed to have a lactobacillus dominant microbiome, and it was beneficial for implantation. RNA data suggests lactobacillus barely exists alive in endometrium, okay? So there may be something there, with metagenomics, with different culture methods, we may learn it, but it's not available yet. And the antibiotic, probiotic treatments don't seem to work so far. And now we have other stuff. There's this wonderful Estonian study looking at extracellular vesicles, right? So it is clear the endometrium is sending messages because it produces the highest number of extracellular vesicles in the mid-luteal phase around the time of implantation. The vesicles get smaller, which means they are more often exosomes, which are like postman carrying messages with different contents. So the only recipient should be the embryo. So there is some activity going on. We can understand immunology with it. There are some preliminary studies, okay? But we need to wait until convincing data comes out, not to repeat the mistakes from the past, jump on the bandwagon, start doing unnecessary tests and interventions. But the most important thing is, whatever it is, Murphy's Law, if anything can go wrong, it will invariably go wrong at some point. So there must be people who have poor endometrial function, which is contributing to their subfertility. But whoever they are rare, okay? And we should choose the study populations very carefully. I would recommend people who fail multiple euploid blastocyst transfers, so you'll rule out other people, so you're more likely to find these rare people. Otherwise, with the best new technology, we'll be still looking for needle in haystack. So nothing is available at the moment to guide clinical practice. I hope we find it one day, but not in too many patients.
Yeah, but there's another mistake, that we're doing in IVF that is very common. You take a measure, let's say 17 millimeters, 10, 7, whatever the millimeters that you talk about it, okay? Let's say everyone said 10. Everyone think that everyone is the same. So meaning you may have completely different metabolism, completely different genetics, completely different everything, and you need to have the same measure, being by the same measure. It's the same thing that if you are 2 meters and I'm 170 or 180, and you need to say because he's taller, he's faster. That's not correct, okay? So you need to really think a little more broaden and try to consider the variations that you have between individuals that maybe, like you just said, maybe in the region that you are, 11 millimeters or 12 or 15 or whatever is more than enough. And in other, you say it, in the United States, maybe they're different. There's something different, right?
They are practicing differently. They are practicing differently because you see, unless you keep track of cancelled cycles, you never figure it out. But since human biology is the same in US, in Spain, in Italy, in Turkey, and everywhere, you would expect it to be similar. So it's practice.
Carlo, you want to say something?
No, I was thinking on something that I invite you to read random 25, 30 papers on ovarian stimulation. And you will always read in presence of at least 2 follicles reaching 70 millimeters, triggering was, probably somebody wrote it for the first time 25 years ago. What does it mean? It means that if you need 2 are sufficient, you are accepting the possibility of the dominant cord is below 17. Mm-hmm. So that's I don't know at that time who wrote it. And even in nature, you can see patients that ovulate when follicles are 19, and patients when follicles are 25. And so we have a lot of stuff that we don't know, cytoplasmic maturation, how much time requires. It's not a matter of size of the embryo.
Yeah, we have a question from Baris.
Thank you very much for you both. Just a very short practical questions for you both. So if we don't trust the 7 millimeters, so what are exactly the investigation of endometrium in your daily practice? What do you do to measure endometrium, to prescribe, to put the day of embryo transfer? What should we do?
That's a
to
very,
investigate the
very
endometrium?
good question. Very good question.
So I think that Baris replied because he mentioned all the possibilities but what I think is that if we think about thickness of the endometrium, probably is not informative. It's something that the problem is, one, we don't have a validated system, so everyone can wake up and say, let's do my... I also had some experiences in the microbiome, and I tried to, because the first problem is sampling. Because a lot of studies sampling is during hysteroscopy, that it makes no sense, because you are putting water inside, you are mixing everything. So second possibility, I do sample with a pipelle, but I'm moving throughout the neck, the cervix, so probably I have to clean inside. And not to, so I tested the same patients with the 3 different methodologies, and the results was dramatically different. And what is important, we don't have a gold standard of endometrial. We say that Lactobacillus crispatus, the only thing that we know at the moment, but I don't know if it is trustworthy in our clinical practice, is this CST classification. So it seems that if it is CST1 in the vagina is associated with a better outcome. And so probably it makes sense to try to reach this. But at this moment, to give an answer, I think that the problem is not the receptivity, non-receptivity, because we don't have a system at the moment to... The problem is understand if there are pathologies of the uterus that can be, that can make the evolution of the pregnancy, the development of roots, the regulatory aspect of immune system. Some pathologies probably can affect early embryo development independently of the receptivity of the endometrium.
If you have everything perfect, okay, let's assume the perfect situation. Everything is perfect. You have an euploid embryo, and you have, I don't know, an endometrium of 5 or 4, 7, or different situations. What do you do?
So the endometrium is perfect, but
everything is perfect. Everything is clean.
But
you have an euploid embryo, and you have a 4 millimeter endometrium.
So up to now, I consider to cancel the transfer because cut and paste from the past. This is something that dogma was don't do it. Yeah. At the moment, probably, if I have, it depends on the number of euploid blastocysts I have. Yeah. If I have 3, 4 euploid blastocysts, I try.
Let me tell you what I'm doing. So the patient will Google it. The patient will, chat GPT it. Someone will mention it anyways. And then you'll be taking a risk. If it works, wonderful. You're the great doctor who moved forward. If it fails, did we make the wrong choice? One, if I see 4 millimeter endometrium, I'm a human being, I can forget things. I read the patient's chart from the start, right? So did we rule out, intracavitary pathology recently, properly, okay? And how was your endometrium before? Because as we're mostly doing frozen transfer, so how was it in the stimulated cycle? How was it in the baseline scan, etc.? So if it's always like that, and then I'm sure there's nothing else in the cavity, okay? So listen, that's your endometrium. I would recommend moving forward. If you have concerns, okay, feel free. Your embryo is frozen. We can try next month. By the way, no, this is not my recommendation. If everything was up to me, I would just move forward. But the patient needs to be involved in decision making.
But there is yes, but there is another aspect. Why we measure endometrium? Because sometimes we don't think it's just thickness, but what we are measuring is the possibility that the endometrium has to expand. If the tissue surrounding the endometrium. We did some trials with hysteroscopy that I had some patients with very, very thin endometrium not growing.
Yeah.
When we put the hysteroscope, the endometrium inside was perfect.
Yeah.
Was perfectly consistent with the proliferative phase. And even biopsies suggested it, meaning that that patient probably for fibrotics, for adenomyosis or whatever, or even echogenicity sometimes, when you have retroverse uterus, sometimes the endometrium has not the possibility to expand to give the typical scanning picture.
Yeah.
But it doesn't mean that viable.
But he says something that I really love, okay? It's like every time that you talk about embryos, who knows what is the diameter of a blastocyst?
The diameter is...
no, don't say it, don't say it. You do, you know. Who knows what is the diameter of a blastocyst? Huh? No, bigger. Probably when they're closer to expand, closer to 200. Now, when they get out, when they hatch and they start expanding, that's a structure that is not going to be probably of thickness. Is going to be not more than, not in length, okay, but in thickness is going to be not more than 50, 70 microns, and you're talking about an endometrium of 7 millimeters, which is 7,000 microns. So it's like a huge space. So now I have you may have questions, okay? So you need to think about that. Now I have a question for you too, and probably for you too if you did it, which is, we try to standardize a measure for every patient in every part of the world to consider it the best time to, you know what, to transfer the embryo, right? For me, that's absolutely wrong. Has anyone did a follow-up of patients, or at least a sample size of patients from different regions around the world to calculate, and you can have different segments of types of patients within the same region, okay? To calculate what is the growth of the endometrium in millimeters per cycle, and what is the final thickness of that endometrium considering the proliferative phase of the endometrium before the LHC. Has anyone did that? In different regions?
I don't know if it's in different regions, but there are observational studies way before, even not necessarily related to IVF. Okay? So what happens is, actually close to ovulation in the last 3 days, it's stunting. I mean, it doesn't continuously keep growing until ovulation. Yeah. It stops growing like 2-3 days before. It's a very, very little change.
Yes, but also in the past, it was trendy, the association between post-triggering endometrium restriction and implantation. But
I said it, I respect Bob Casper immensely. He was a pioneer, he's a genius, you know. Anyways, but remember the person, so the compaction study came from their clinic again. So when I read it, you know, so it was a retrospective analysis.
Tell them what they did, because he was not only looking at the thickness, but he was looking at the compaction.
What they did is they compared the endometrial thickness on the day of trigger versus the day of the embryo transfer, okay? And the idea is when it's exposed to progesterone, when it undergoes secretory transformation, you could expect it would shrink to some extent. And then if it doesn't shrink enough, maybe there's something wrong with it. But the thing is, you know, the paper, the measurements were done on frozen images of transabdominal ultrasound at the time of embryo transfer that was routinely captured, not for such a particular study even. Okay? So that's the first paper. Now, even when you try to measure endometrial thickness, for the sole purpose of measuring endometrial thickness with vaginal ultrasound, you saw how variable it is. Then this is with abdominal ultrasound, not even for the purpose of measuring endometrium necessarily. And then the compaction, so assume it's 8 millimeters on average. Compaction of 10% is 0.8 millimeters. how can you be that precise to measure it? Okay, so it was clearly, it wouldn't work. And then as it was easy to study, 10, 15 papers came out in 2 years. Once you combine them, it doesn't make sense anyways.
Yeah, now, what you said, and well, both of you said in the study is basically what it could be normal thickness for one, it may be abnormal for other and vice versa. So questions from you, because you must have questions. This is a very important topic because you can do everything really right.
Diego, may I ask a question? I'm sorry for interrupting. So just, I need to see. How many of us today is doing IVF, started doing IVF after 2011? 2010, 2011.
After 2011, raise your hand.
After. Like how many? Few still.
Okay.
So
few.
like the majority has been done this for longer.
Yeah.
So now, today, the subject is why do euploid embryos fail to implant? I remember 20 years ago, 18 years ago, we had similar talks, similar discussions, and what was a euploid embryo then? What's a euploid embryo today?
Yeah.
A euploid embryo, now if I tell you today, listen, I invented a test, I can check maybe 6 chromosomes of a blastomere.
With one blastomere?
With one blastomere, 6 chromosomes and not the entirety of the chromosome. If my antibody binds to a certain portion of the chromosome. And then if I ask you, can you tell me why it's failing to implant?
Exactly.
Actually, today, this comprehensive chromosomal screening doesn't mean the embryo, even only in terms of DNA sequence, is perfect. Right? So it's still not 100% resolution. Right? So there's still a limit of resolution. Depending on the test, could be whatever, 10, 15 kilobytes.
Yeah,
right?
yeah.
And then the sequence is not everything, which is expressed. We know euploid embryos, day 5, day 6 are different quality-wise, like morphological quality are different. The only thing that I understand from all this thing so far, consider patients infertile for 15 years, underwent 5 IVF cycles, none of which worked. Then one day they walk into the clinic with pregnant. So it's usually, you getting the right embryo. We are still far from assessing the embryo. And the cumulative live birth rate data, that doesn't matter if it's 98%, doesn't matter if it's whatever percent. The trick is, unless you see a progressive decline with consecutive embryo transfers, which Dominic Destoop published recently without PGTA, if you follow up people, if they're resilient enough to undergo 10, 12, 13, 14 transfers, still you reach 96, 97%.
Yeah.
Okay? And every transfer almost has the same chance. So that means most of the time it's the embryo, and we are still far from assessing it.
Totally, but still, you know what, you may have a variability that you can eliminate if you do an objective measurement of the implantation, the receptivity potential of the endometrium, right? Sure. There's nothing now, but there is a company. Do you know who is Roger Pearson? Do you know who is Roger Pearson? Roger Pearson was the guy that taught me ultrasound in the 80s, okay? He started working in animals and then he moved to humans. And he is one, a genius doing ultrasound. And he's working with a company called Future Fertility. We were working with them to try to develop a system that is going to be able, with ultrasound, to measure objectively using artificial intelligence the receptivity of the endometrium. And they are just developing that tool with this company, Future Fertility. They've been developing the tool for 3 or 4 years. I don't know when it's going to come or not. But I think that is a gap that is existing. We still do not have an objective measurement that can say that this endometrium, before transfer, not in the previous cycle, before transfer, is in the perfect stage for transferring or not. So I love the discussion, and you have questions, great, ask questions, come on, if not, they're gonna leave and you're not gonna have answers.
Yes, hi, thank you for great talks. I have a question. In my country, in Armenia, there were lawsuits against the case, and I was involved as an expert. The transfer was for an endometrium 0.5 millimeter, and the patient was suing. She didn't get pregnant. She was suing that why it was so low, so there was mistake, etc. So do we have any guideline, anything that will cover us juridicially if we will make transfers for 5 or 4 millimeter endometrium? Do you think that we will have this kind of guidelines? We need to be covered. Huh?
You do have that guideline. It's called the ESHRE Ovarian Stimulation Guideline. If you read the endometrial, I mean the stimulation, well, endometrial thickness, there's a small chapter on it. It says, you may inform the patient, maybe the chances of pregnancy could be lower, but it recommends not changing your management based on endometrial thickness. It was the same 5 years ago too.
So no cutoff specifically mentioned.
No. Nobody can come up with a evidence-based cutoff. The ESHRE guideline is evidence-based.
Still with the 7 millimeter in our parts of the world, 10, it depends. But any questions? Yeah, questions. Good.
Thank you for both of speakers. You are prominent and we are lucky today, the audience. So both of you are very famous regarding adenomyosis. So my question, let's turn to this topic, okay? So do you have an experience with using these high-density local energies, HIFU, the magnetic resonance, the ultrasound locally? I have very difficult patients. She had adenomyosis like 18 weeks of pregnancy, 6 months. First she started with GnRH agonist together with aromatase inhibitors. Now she's in antagonist with adds-on therapy because she's bleeding and etc. And she had 3 failed IVF attempts with euploid embryo, and she's still very active. She wants to she does not think about surrogacy and surgical methods because they're also dangerous from obstetrical point of view. So what you would recommend me, please? Thank you.
So probably we have to accept the idea that there are some kind of uterus that we cannot treat, because there are sometimes when we have distribution of the adenomyosis involving the entire myometrium, there are some pictures that, so obviously at the moment I read that many attempts that have been done with the combination of IUD with levonorgestrel or oral antagonists associated or not with norepinephrine. So a lot of stuff is coming up, but at the moment we don't have any evidence that something is better working than other kind of stuff. Surgery, I cannot understand the indication to surgery when it is not local, specific, and approachable adenomyosis. So I don't think that, I don't have experience with radio frequencies, ultrasound, this I don't, because it's interventional. We need ethical committee approval to do something like this. I don't have, I don't know.
So I even do surgery sometimes when it's focal.
When it's focal.
Nice videos, but the other thing, so in surgery you remove the area. If it's like submucosal, so there's not much defect anyways, and whatever, myometrial, you can suture somehow, flaps. Yes, it's last resort. But the other tissue destructive techniques, be it by focused MRI, be it with these needles, etc. So what happens with adenomyosis? Eventually the tissue becomes fibrotic, right? It starts distorting the cavity. And remember the story with, so nothing can reverse fibrosis so far, right? So you can kill the other cells, but then fibrosis, I don't think it would relax. So if you remember the history of embolization for fibroids, okay, the early data suggested obstetric outcomes were similar. It may be appropriate for patients seeking fertility. Then as data accumulated, we started seeing obstetric problems. And I once happened to operate on a patient with numerous fibroids who had previously undergone embolization. I have the video of it on my computer. Wherever you hold in uterus, it just drops. It's just dissolves. So the tissue is gone. And then I became part of the problem by accepting to operate on her. So now that adenomyotic uterus to that extent is a huge problem already. Okay, And I wouldn't, the data is not there yet, but I wouldn't, personally, it's my choice. I don't say it's evidence-based. If I were a patient, extremely unlikely I would accept a tissue-destructive technique if I want to conceive later, okay? So we need to see the data, but not my expectation, it's not what I hope, but what I expect to happen is unlikely those tissue-destructive techniques will improve the outcomes. So still the best would be, endocrine suppression.
Any other question from
Endocrine
the audience?
suppression.
You have Nicola. Oh, she raised her hand first. Sorry.
Thank you very much for great talks, and I have a question for Carlo about your personal attitude to applying with severe adenomyosis antagonist if we compare with agonist.
In the ovarian stimulation?
No, before cryo-embryo transfer.
Yes, there are somebody reporting the use of antagonists, oral antagonists. Oral antagonists. So now Linzarelli-Rolix is also an option, and there are so many molecules. But the problem at the moment is understanding, because with the Linzarelli-Rolix we have also the possibility of changing the dose with respect with the Relugolix. But the problem is that we don't have trials at the moment. We can try, and then but if we don't have a minimum of data analysis, or because the problem in this kind of patients is also understand which kind of adenomyosis we are treating. So we should randomize, for instance, patients where the junction, I agree with Baris that sometimes, given that the problem is the stability of the inflammation in the junction, surgical approach can modify, can be even to abuse of hysteroscopy. We don't know always if we are doing the right thing in treating. And so at the same time, I don't think at the moment we have sufficient evidence to say, even with antagonists, with an agonist, when I tried to understand how many papers had been published, which level of evidence we have at the moment, there are only few papers published in Asia-Pacific testing, randomizing to receive or not to receive agonist, generate agonist before transfer in cycle segmentation, but the number of observation at the moment is very few.
Okay, thank you so much. But after all these beautiful lectures, after all said and done, I want to ask you both a very simple question. Does it mean, for you and for you, that there's no red lines in endometrial sickness, and that every endometrial sickness is suitable for transfer, and you personally in your practice can ignore endometrial sickness and then numbers 1, 2, 3, 4, 5, 7, and for what extent? That's my question.
Short answer, I've been doing that for more than 10 years now.
No red lines. Perfect. Thank you for your response.
No, I reply with another question to Baris, to all of you. So we know something, and we discussed a lot about it, that 50% of euploid embryo will implant and 50% not. We have 50% to justify. So the question could be, one is the endometrial receptivity, probably yes, but it's a very rare condition. Synchronicity, yes, can explain, but my question is, in the 50% of embryo that don't implant, despite a good uterus, in which percentage it is an embryo variable? Not synchronicity, not uterus, but something different in embryo, which is not aneuploidy related. So how much can we identify oocyte quality with the euploidy?
You know, the vast majority, if I got the question right, you know, in what percentage of failures it's the embryo rather than the endometrium, right? In the vast majority. That's what the data consistently shows, okay? And implantation rate is way higher. Live birth rate is about 50%, okay? So it depends. You know, PGTA is extremely operator dependent. Not every euploid is the same, depending on the IVF lab and the genetics lab. But let's say what we observe is almost 70% constant implantation, but still, you know, 55 to 60 live birth. And as Paul Pirtea study, the second study, I mean, the multi-center we did, which expanded on it. Now, Dominic Destoop study, as consecutive embryo transfers in the same patient have similar chance of live birth, there's no obvious enrichment of an obscure endometrial factor in the denominator. It must exist, but it's very rare.
Thank you.
I want to make a comparison. I normally like to make comparisons to real life, okay? And probably it's going to be the last thing that we're going to talk, because we can stay talking for hours, okay? And questions are going to come. But I live in Boston, you know, 30 kilometers south Boston. And I've been there for the last 25 years, okay? I have my backyard. You were in my backyard, right? So the backyard is full of green grass in spring and summer. Now, there is one area of the backyard that the grass is not coming, you know? So what did I do? I normally put some seeds. So I try to find the seeds that are the best seeds. I put the seeds, I put water, fertilizer, whatever. It didn't grow. Then they sell, in the United States, they sell some seeds that they say that you can put it in pavement and they will grow. I did the same thing. I put it like in pavement because it was not growing. Water, all that stuff, yeah, it was not growing. Do you know what I did at the end? I just took a sample of the soil. I sent it to university and I told them, give me the analysis, what's wrong here that the grass is not growing. They gave me the analysis. They told me, look, this area is lack of this, this, and this. This is what you need to put. They gave me the formula. I put the formula. I put regular seed. The grass is green. So even though the majority have been, you know what, taking with embryos that are euploid, getting pregnant, still you have a percentage that will not. And you need to investigate really what is it, okay? So it's a simple example. I want to thank these two guys and friends that did an amazing job just to talk about things that are really important. So they deserve a big round of applause, okay? So
thank you.
Carlo, Baris, thank you so much. And I want to tell you one thing. Is like I've been for the last 4 days here in Paris, and I only went to 2 symposia. That's it. And this is my that's why I'm so eager to talk, you know what, and ask questions, because it's the first session that I have science, and I thank Ostap, and I thank Vlad, and I thank the entire team for including me, because for me it's always a pleasure to see you and to share the knowledge of these guys, okay? So thank you so much.
Спасибо огромное. От лица компании хотел бы поблагодарить.
Thank you very much. On behalf of our company, we would like also to thank all the participants, speakers, and moderators. Thanks a lot.
I would like to say a lot of warm words. Thank you. It was amazing presentation. It's a lot of experience, a lot of new knowledge. Thank you. We wait you next time. Next time, exactly, because I think our events, it's a great event. Thank you. Thank you again. Thank you. Уважаемые коллеги, у нас...
Dear colleagues, there will be a reception. You know, it's like a piano in the bushes. We will join in formal communications. Thank you.